Good morning. John Sheen is my name, and I'm a GP here based in Cork. I'd like to welcome you all to the GP Masterclass this morning. And I'd like to thank Menarene for their help and support in organising this Masterclass. I'd like to introduce you to Francis Lynch, who is the General Manager for Ireland, who's going to say a few words this morning before we begin our session.
Okay, good morning. My name is Francis Lynch. I'm General Manager of Menarene Pharmaceuticals. Welcome to our first of our 2020 webinars, masterclass webinars, I should say. Obviously, we're all used to this stage to the peculiar times that have COVID-19 represents. We're very thankful over the years in Menarene for your welcome of our medical representatives. Obviously, we haven't been visiting our practices since the middle of March, and we very much look forward to the opportunity to going back to that particular situation. In the meantime, we wanted to continue the tradition of medical education by organising these masterclasses in the virtual way. And later on, one of our representatives will talk to you about some of our products in over 8 therapeutic areas that we are supporting. So we very much look forward to that opportunity. I'd like to thank our chairman for today, Dr. John Sheen of Blackpool General Practice and General Practitioner. We're very thankful for his time to organise and to be part of this meeting. We're also joined by speakers Dr. Oisin O'Connell, Consultant Respiratory Physician here in Cork, Dr. Karina Sadlier in Infectious Diseases in Cork. We're also joined by Dr. James Dollar, Consultant Cardiologist in Cork. So we look forward to a very productive meeting, and thank you for logging on to this meeting, which also will be available for viewing in the future. So thank you very much, and I hope you have a productive meeting.
Thank you, Francis. Thank you very much. This morning we have 3 speakers, and I think it's a very interesting and informative morning. The 3 speakers have expertise locally in their fields, but particularly, I suppose, in relation to COVID over the last number of months, which has certainly changed the world for all of us. We've all got used to doing things differently. We've got used to doing things online. Our educational, I suppose, approaches have been very, very different. And I suppose locally here, I'd like to thank Francis Sweetman for helping organising this, because I think this is very relevant to all of us here in Cork and the surrounding counties in terms of our dealing with COVID and how we approach things. We have a very exciting and I suppose informative speakers this morning. First of all, we have Oisin O'Connell. Oisin is a respiratory physician in the Bonds, and I had the honour of teaching him many years ago when I was working in epidemiology and public health, but he has gone on to much greater and better things since. Oisin is going to talk about some of the challenges in terms of dealing with COVID and some of the challenges that they have encountered in terms of his role as a respiratory physician. This is following by Karina Sadlier, who's an infectious disease consultant in CUH. And Karina is involved in terms of COVID on many fronts, and I'm sure you've probably seen her on Primetime and other programmes during the crisis. It's followed then by James Dollard, and James is a cardiologist who is working in the Mater Private here in Cork, and prior to that worked in the Mercy Hospital, and we'll be talking about some of the cardiological aspects of COVID, which I suppose as time goes on we're becoming more aware of, and as our understanding of the disease is progressing. So they're very interesting speakers, and I think they're very relevant to what we as GPs are doing on a day-to-day basis, and I think we will all learn and benefit from these talks. There is a question and answer function on the website, and I'd encourage people to submit questions, because as each speaker finishes, they will be coming back on and there will be an opportunity to ask questions. So if anyone has any questions, we certainly would encourage them to submit questions. So now I'd like to introduce the first speaker, Oisin O'Connell. Oisin has had much experience, I suppose, in dealing with COVID, but also in terms of the whole PPE, infection control, his role as a respiratory physician, and some of the challenges that he has faced, but also some of the challenges that we are likely to face down the line. So now I'm going to hand you over to Oisin. Thank you.
Hello all, and my name is Oisin O'Connell. I'm a respiratory consultant in the Bon Secours Hospital, and I'm going to be giving an update on COPD and talking a little bit about the implications from a COVID perspective. I'm going to predominantly focus on COPD and where we're at nationally with COPD. So chronic lower respiratory disease, primarily COPD, was the third leading cause of death in the United States in 2014. In fact, 30% of subjects with airflow limitation and COPD have never actually smoked, and that was in the Lancet in 2009. The following groups are more likely to be reported to have COPD, and that would include women, people between the age of 65 and 74, and then there's a lot of other kind of risk factors which we'll cover in several further slides. So what is COPD? Different people will use different definitions, but essentially it's a clinical condition characterized by irreversible airflow obstruction and preceded by a noxious stimulant. Now, we're most commonly familiar with smoking as the noxious stimulant, but essentially there's different forms of airway inflammation and patterns of inflammation. In particular, we talk about kind of eosinophilic inflammation, neutrophilic inflammation, and one of the concepts and themes of the night that I'll talk about is how the lungs are like a series of pipes leading into balloons, and how we can think of this analogy when we're thinking of COPD. This is just a diagram showing the global mortality and shows that COPD is the third largest cause of deaths globally, and this has actually strangely been decreasing by 1% per year for COPD. So COPD actually represents 5.3% of deaths globally, and in fact this is more prevalent in countries such as India and China, and in fact a large number of people in India and China have not actually smoked and yet have obstructive airways disease. So this is just a diagram globally showing the kind of social demographics associated with COPD, and in industrialized countries it's much more likely that people will have smoked cigarettes, and in non-industrialized countries it's much more likely that other noxious stimuli will be the cause of their obstructive airways disease. So you can actually see there that in the certain countries there, the dark bar makes up only 23%, so smoking only causes 23% of chronic obstructive airways disease in certain countries. In terms of Ireland, there's 500,000 patients in Ireland thought to have chronic obstructive airways disease, and 250,000 of these may not be diagnosed. Ireland's got the highest incidence of hospitalizations globally for chronic obstructive airways disease and makes up 5.8% of all hospitalizations nationally. So if you compare the number of bed days for chronic obstructive airways disease and hospitalizations compared to the OECD average, we're almost double the OECD average in terms of bed days spent in hospital for COPD. And there is in fact a kind of a variation nationally as to how this is about. So interestingly, the kind of what we deem the fresh air countries, the ones around the outskirts where we think of good air and lower population density, have got a lower incidence of chronic obstructive airways disease. Looking in terms of mortality around the world, actually, the world and hospitalizations have shown a significant improvement in all-cause mortality, particularly coronary artery disease, yet it's actually remained pretty static for chronic obstructive pulmonary disease. So over the past few decades, we have not significantly improved survival for COPD in hospitalized patients. Another common theme in terms of chronic obstructive airways disease is the overlap between asthma, COPD, and where they meet in the middle, the asthma-COPD overlap syndrome. In In terms of smoking, we are all aware that there's been a significant reduction in the amount of smoking globally, but in parallel to this, there is an increase now in vaping, and we're starting to study more as to what kind of vaping may do to the lung. Some people may have seen some of these reports on bilateral lung infiltrates associated with vaping. This was even before COVID came about, but it's thought that some of the fatty lipid acetates used in the emulsification of the vaping may actually cause an acute lipid pneumonitis and present with bilateral lung infiltrates, and has actually resulted in some patients being hospitalized, and there's a better understanding now of the commonality as to the mechanisms behind this. I use this concept a lot, the lungs like a series of pipes going into balloons, and I sometimes use the term the bronchial tree. The bronchial tree refers to your main stump, which is your trachea, divides in two, and as we divide out, the lung divides into about 25 subsegments or 25 branching patterns, and the further out the branching pattern you go, the larger the surface area for gas diffusion to occur. And what tends to happen in COPD is you get a loss of the balloons or the alveoli to the outer skirts of the lung, and the alveoli that remain tend to increase in size. When I'm describing lung disease to patients, I often use the term we all lose lung function over time. Ex-smokers and people with chronic obstructive airways disease tend to lose lung function faster than other people, but we're all losing elasticity in our lung. There's significant correlation between your dyspnea score as measured by your MMRC and your gold stage ABCD score and your mortality. So for a gold group D with an MMRC of greater than or equal to 2, your 3-year mortality is actually 35%. So dyspnea correlates a lot with mortality in COPD. Getting back to the phenotyping concept, we sometimes talk about COPD, we talk about asthma, and we talk about asthma COPD overlap syndrome, and this is one of the groups called the SARP group. They've done this analysis of asthmatic phenotypes, and they've actually done a cluster analysis and shown that there are clusters of asthmatics with obstructive airways disease, and one way you can distinguish the two is COPD tends to have a parallel reduction in your DLCO, or your diffusion capacity for carbon monoxide, whereas your obstructive asthmatics tend to have an FEV1 to FVC ratio of less than 0.7, but they don't have the concomitant loss in their DLCO as your COPD patients. This graph here is just showing that the frequency of hospitalizations is associated with mortality, and actually there is a parallel effect, meaning the last exacerbation you have is a predictor of the time to your next exacerbation. And what you tried to do is think of game changer moves to break the cycle in terms of COPD exacerbation. Another evolving concept is the variation in your peak lung function, and this tends to form in your kind of years around your 20s, and depending on how good your lung function goes at that time is kind of correlated with the slope of decline in your lung function thereafter. So some people never reach their peak lung performance in their 20s, and as a consequence of that, the effects of losing lung function over time becomes more dramatic and more apparent. So if you've had extremely good lung function in your 20s, the speed or slope of decline in your lung function will correlate ultimately with your FEV1, but it actually can vary as to whether you end up with obstructive airways disease or just relatively small lungs and essentially a restrictive lung pattern spirometry. This here is just a DCAF score. It just refers to a prediction model for predicting your risk of mortality associated with COPD. D refers to your dyspnea as measured by your MRCD score. E, your eosinophilia. C, constellation. A, moderate or severe acidemia, and F atrial fibrillation, and you can have different scores based on that correlating with your mortality. We're all familiar with the benefits of stopping smoking. This here is just a graph showing the difference in mortality if you can manage to get someone with chronic obstructive airways disease to stop smoking. I'm going to break the next part of the talk up into monotherapy, dual therapy and triple therapy, and just kind of give you a sense of the different ways of managing obstructive airways disease. So we're all familiar with the ABCD score for assessing COPD as per the GOLD guidelines, and this has evolved a lot over the last number of years, and if anything it's become remarkably complex, and we'll talk about ways later on to talk as to how to make this easier. But essentially you look at your mild, moderate, severe and very severe based on your FEV1, then you categorize them into ABCD depending on the level of dyspnea and also the number of hospitalizations and the progression of their disease. So in terms of the initial therapies, we talk about group A getting a bronchodilator, group B starting off with a LABA or a LAMA, group C getting a LAMA, and then we talk about group D and the frequent exacerbators. And then the 2019 GOLD guidelines kind of use this nice diagram. It just shows when you use a LAMA-LABA, when you use a LAMA inhaled corticosteroid, and when you use combinations of all three. I suppose in any implementation or assessment of somebody with COPD, we all need to be thinking of the initiation, the implementation, and the persistence, and how we can strive to achieve that. Moving on to dual therapy, there's a high symptom burden persists in most patients with monotherapy, and as such LAMA-LABA is superior to monotherapy in improving quality of life, lung function and symptom control. The early use of LAMA-LABA may preserve or serve to stabilize COPD longer than LAMA therapy alone, and there's a number of benefits of LAMA-LABAs over monotherapy without an increase in adverse effects. A high symptom burden persists in 50% of patients on a LAMA monotherapy, long-acting methacholine agonist monotherapy. And as such, these are the GOLD guidelines. Start off with a LAMA-LABA for a dyspneic patient, and then you start moving on to combo inhalers depending on dyspnea and exacerbations. Over 50% of patients with COPD receiving a LABA-LAMA experienced a moderate or severe exacerbation over a 1-year study in the New England Journal, the FLAME study. I'll talk about a number of different studies looking at LAMA-LABAs. The Dynagito study was published in The Lancet in 2018, and it was the use of tiotropium, which is a LAMA, and aldactorol, which is a LABA, long-acting beta agonist. And it's been previously shown that the addition of a LABA to a LAMA offers improvements in lung function, symptoms, and quality of life, and they're just the inclusion criteria. And essentially, this study showed that the LAMA-LABA was superior to the LAMA alone in terms of moderate or severe COPD exacerbations. And this is just another dramatization of that, looking at the change in the CAT scores from baseline between those on a LAMA in red and a LAMA-LABA in blue there, which is the difference in as I say, the CAT scores. The Sunset study, so in non-frequently exacerbating COPD patients with an FEV1 of 40 to 80%, what are the adverse consequences of de-escalating therapy? And the answer is you get decreased lung function when you de-escalate therapy. So what the Sunset study was the long-term triple therapy de-escalation in COPD patients, and it was a randomized trial. This was based following the Wisdom study, which evaluated the stepwise withdrawal of inhaled corticosteroids from triple therapy in COPD with a history of exacerbations. I won't go through the details of the study, but that's essentially the background and the objectives. And the inclusion criteria, so essentially it's those with post-bronchodilator FEV1 between 40 and 80% predicted, and as with all obstructive airways disease, having an FEV1 to FVC ratio less than 0.7. And the direct de-escalation led to a small decrease in trough FEV1 of 26 mils in FEV1 difference. So those with triple therapy, meaning the addition of an inhaled corticosteroid, had a 26 mil improvement in their FEV1 as compared to those with an FEV1 to FVC ratio, as compared to a LAMA-LABA. Looking at the subgroup analysis, actually, depending on the serum eosinophil level, you could actually distinguish out who got such a difference in terms of benefit. So if you had a serum eosinophil level of less than 0.3, there was no difference in the groups, whereas if your peripheral circulating eosinophil level was greater than 0.3, they did find a significant difference between the inhaled corticosteroid group and the dual therapy group. So in conclusion, they said we could not confirm non-inferiority of a LAMA-LABA to triple therapy. Inhaled corticosteroid led to a reduction in trough FEV1 of 26 mils, and there was an annualized rate of moderate or severe exacerbation did not differ between the different groups. So the triple therapy versus the LAMA-LABAs. In conclusion, there was a small decrease in FEV1 seen primarily in the subset of patients with blood eosinophilia greater than 300, no difference in risk or rate of exacerbation, and these results are clinically relevant and may support personalized management plans. Getting on to triple therapy, what are the benefits of triple therapy versus LAMA-LABAs? So in summary, it seems to improve lung function, reduce acute exacerbations of COPD, improved health-related quality of life, and reduced mortality. A number of studies kind of backing this up were the Tribute studies, the Fulfill trial, and the Trinity trial. So this is from the Canadian Thoracic Society. They suggest that triple therapy is recommended for the management of COPD in patients who have clinically significant symptoms despite treatment with an inhaled corticosteroid LABA or a LABA-LAMA, who are at increased risk for frequent or severe exacerbations. Prior studies have shown triple inhaled therapy has positive effect on lung function and symptoms compared with dual therapy. This is a complex diagram from the New England Journal, but it's just showing that a lot of this is on a spectrum, and really symptoms of dyspnea, and exacerbations affects a lot of the flexibility as to what is the best inhaler therapy for a patient. Looking at a subgroup of analysis in the Lancet, actually, the peripheral eosinophil levels correlated extremely well with both FEV1 and annual infective exacerbation rate. And actually, what the blue line here is formoterol monotherapy versus the red line, which is budesonide formoterol. So looking at a LABA versus an inhaled corticosteroid with a LABA, and the upper graph is your FEV1, and the distinction when you get to 0.1 peripheral eosinophils, you find that the FEV1 starts to separate out in terms of annual infective exacerbation rate and FEV1. So very similar to this kind of asthma phenotype in COPD patients, and it gets back to the earlier slide of asthma COPD having quite an overlap. So what we're starting to see is that inhaled corticosteroids seem to be associated with improved lung function, and it seems to correlate extremely well with peripheral circulating eosinophil levels. And this kind of holds true in several different studies. So the red line here is the probability of an event, and essentially the FF refers to the steroid fluticasone, and essentially the combination of medications where you've got an inhaled corticosteroid has a reduction in mortality and essentially an improvement in lung function. And this again is the same here. the triple therapy is the blue line, and essentially moderate or severe exacerbations tend to be improved in terms of triple therapy. But actually, if you look lower down, you can see the risk of pneumonia, and they're kind of, the lines are the inverse of each other. So actually the triple therapy has the highest risk of pneumonia, but the lowest risk of exacerbations. And this correlates extremely well with the circulating peripheral eosinophil level. And this is starting to become a recurring theme now, that the blood eosinophils correlate to corticosteroid responsiveness and to COPD exacerbation. Now, I suppose, why do we need to be cautious with steroids? Well, the dose of steroids that you get correlates with your risk of pneumonia. So what we're trying to do is work out your risk of an infective exacerbation of obstructive airways disease versus your individualized risk of pneumonia. And the graph over here on the right shows that if you have a high amount of inhaled corticosteroids, you have a 2.5-fold relative odds ratio increased risk of pneumonia as compared with somebody not on steroids or somebody on a low dose of an inhaled corticosteroid. So you need to titrate your dose of inhaled corticosteroid to your risk of obstructive airways disease and COPD exacerbation. Why is this important? Well, the risk of death correlates extremely well with your risk of pneumonia. So if you've got gold stage 4, your risk of death and your odds ratio is 3-fold higher when you have a higher risk of pneumonia. So the worse your lung function, the worse the stage of your COPD, the higher the risk pneumonia has on your own mortality. So that's just another graph essentially dramatizing that, but it gives you the number needed to treat and the number needed to harm. So the number needed to harm for a LAMA-LABA plus inhaled corticosteroid in terms of causing pneumonia is 33. The numbers needed to treat are, for every patient treated with a LAMA-LABA inhaled corticosteroid, it prevents 1 moderate to severe exacerbation, and for every 16 patients treated with LAMA-LABA inhaled corticosteroid, it prevents 1 severe infective exacerbation of obstructive airways disease. In terms of other kind of things to do with COPD, we'll talk about the reduced study. Essentially 5 days of steroids seems to be better than or as equal to 7 days as 14 days, and this came from a Cochrane meta-analysis. So COPD, different to asthma in terms of the duration of steroids, shorter courses are good. Oral steroids are generally good at short doses. Azithromycin, there's a number of studies out now suggesting that azithromycin in COPD reduces infective exacerbation rate annually. This came from a study in San Antonio, and they looked at the airway microbiome, and they specifically excluded those with atypical mycobacterium in their lungs. And looking at the kind of various different patterns of airway microbiome and the predominant organisms, meaning Pseudomonas, Haemophilus, MRSA, Streptococci, and treating these patients, irrespective of the sensitivity to azithromycin, was associated with a reduction in infective exacerbation rate of chronic obstructive airways disease. There has been a perception that azithromycin works preferentially in those with neutrophilic mediated airway inflammation as opposed to eosinophilic airway mediated inflammation, and it's thought that azithromycin inhibits neutrophil chemotaxis to the lungs. And it resulted in a relative risk reduction in infective exacerbation rate from 1.86 down to 1.07. So an approximate absolute risk reduction of 40%, I understand. And that was the AMAZE study. Apps. I mentioned earlier that COPD is getting more and more complicated to figure out into which group somebody falls. Are they in A, B, C, D? And this is just one app that you can download onto your phone. It's called the COPD Pocket Consultant Guide, and it gives you a quick way of going through the CAT score, the MMRC score, the inhaler education, exacerbations, and to specifically actually tell you what is the next line of treatment for an individual patient and how best to work that out. And it can essentially risk stratify a patient, so save you kind of working out a lot of what seems to be relatively complex algorithms in the 2019 guidelines. So the other big term that's coming out in terms of COPD is care bundles coming out of hospital, focusing on patient education, pre-discharge, individualized self-management action plans, and timely outpatient follow-up with their doctors. Lots of different ways that these can be done in terms of home monitoring, e-health and teleconference, and there's a lot of emerging evidence around pulmonary rehabilitation programs online. The COMET study was a multi-component home-based disease management program versus routine care in severe COPD. Action plans, just to be aware, there's a number of different national action plans. The HSE have the end-to-end COPD model of care. There's national clinical guidelines for management of COPD. There is the ICGP and Irish Thoracic Society have the chronic obstructive pulmonary disease quick reference guidelines, and we're all familiar with the goals 2019 updates. This is a useful link, and you can hopefully take this down, but essentially on the HSE website there is a COPD self-management action plan. It's a bit like your asthma home action plan, and again, this is new on the HSE website, and patients can actually basically rank how their symptoms are and get advice based on how they're feeling on a given day, from feeling well to bad day to feeling unwell or very unwell. This here is the COVID National Plan for Management of COVID in Hospitals. I've seen multiple variations of these, but essentially they've risk stratified into A, B, C, D. Now this is nothing to do with goal. This is down to your risk of severity of COVID when you're in hospital, and they're stratifying it by the amount of oxygen you are requiring. In terms of non-invasive ventilation, there's a number of studies out in terms of the use of home ventilation in COPD. This study in JAMA in 2017 evaluated home non-invasive ventilation with oxygen therapy versus oxygen therapy alone, and shows that there's a complete game changer in terms of management of severe exacerbations. And what they found is that home non-invasive ventilation delayed the time to readmission for type 2 respiratory failures from 40 days to 120 days, and they concluded that in patients with decompensated type 2 respiratory failure admitted with a COPD exacerbation, the initiation of home NIV would improve survival and reduce the need to readmission. We're all familiar with pulmonary rehabilitation. I suppose in COVID times there's a number of online pulmonary rehabilitation programs that people can access that seems to correlate with a reduction in admissions. So to summarize the non-COVID part of the talk, triple therapy decreases acute exacerbations of COPD. There does not appear to be an increased acute exacerbation of COPD in moderate to severe COPD patients. There's multi-component disease management and telemonitoring. Home NIV is beneficial, and 5 days of steroids are generally sufficient. I've got about 7 to 8 slides on COVID in COPD times. So we're all inundated with information on COVID. The risk of COVID in terms of fatality, if you get admitted to hospital now, this obviously varies by time, but in May, if you were admitted to hospital because of COVID, you had a 7% mortality. The Global Burden of Disease Study 2017 said there was 3.2 million deaths annually due to COPD and 500,000 deaths due to asthma. The CDC reported that mainly asthmatics as the second most prevalent comorbidity in hospitalized COVID-19 patients aged 18 to 29. And an analysis of 1,590 COVID-19 patients across China found that COVID carried an odds ratio of 2.6 for ICU admission, mechanical ventilation, or death, even after adjusting for age and smoking history. And that 62% of severe cases had a history of COPD, and 25% of those who died were COPD patients. Now, we already mentioned there are a different demographic in China, there's different risk stratification, and that only 23% of Chinese patients with COPD have actually smoked, and it's actually of kind of lower socioeconomic class in China tends to be associated with a higher risk of COPD. So there's a lot of confounding factors in this. But looking at the odds ratio across 6 studies of COPD in Chinese patients, it shows an odds ratio for increased risk of death of between 5 and 8 in general. Again, just looking at the cumulative survival or probability, this is just a Kaplan-Meier survival curve of COPD versus no COPD in a Chinese study of COPD patients with COVID in China, and showing that COPD is an independent risk factor. So what we're expecting this winter is there will be a significant influx of patients with lingering long COVID illness, both physical and emotional, and GPs are likely going to not have the necessary resources and supports to deal with the volume of patients that are going to be coming through. A team of researchers from Italy report that nearly 9 in 10, or 87% of patients discharged from a hospital were still experiencing at least one symptom at 60 days. And they found that 13% of the 140 patients were completely free of symptoms, while 32% had 1 or 2 symptoms, and 55% had 3 or more. These included fatigue at 50%, dyspnea at 40%, joint pains at 27%, and chest pains at 22%. The post-hospitalization COVID-19 study aims to recruit 10,000 patients across the risk across the UK, who will be followed up for more than a year. In terms of how does SARS affect the lung, it seems to gain entry through the ACE2 receptor, and there's also this TMPRSS2 receptor, and it's thought that it enters via the ACE2 receptor, gets into the bloodstream, causes endotheliitis, exposes one von Willebrand's factor in the endothelium, and causes both a pneumonitis from the SARS infecting or accessing via the ACE2 receptor, and an endotheliitis causing pulmonary microthrombosis, and causes basically kind of a local shunt phenomenon. Now, that's one of the mechanisms. There's also the recent bradykinin model, but essentially it's thought that steroids may affect the production of ACE2 receptors inside in the lungs. So in terms of the guidelines around SARS and COVID-19, we regard most of what we do in terms of nebulization as aerosol generating procedures, so it can increase the risk of airborne transmission. We now know that COVID can transmit not alone by droplet, but it can be aerosolized. My description when I'm describing this to patients is think of cigarette smoke, and think of cigarette smoke coming out of somebody's mouth. Can you smell it? And can you see the smoke getting around the rooms? And I think that's a good way of dramatizing or representing it to patients. You should monitor as an inpatient or outpatient will be done on an individualized basis. Patients' ability to engage in monitoring in home isolation and risk of transmission in the home should all be considered. A recent systematic review and meta-analysis reported a 4-fold increased risk of development of severe COVID associated with COPD, and a 2-fold odds ratio in those that had ongoing cigarette smoking. So what we're going to be presented with, COPD presents in large numbers of scans. Lung function curtailment is going to be a huge issue for all of us. We have significant reduction inside in the hospital because essentially we've been told in the hospital environment you're supposed to have an airflow exchange of 15 times per hour and 5 times before you can get the next patient in when you do an aerosol generating procedure. So trying to gain access to spirometry and pulmonary function tests is going to be a major issue for all of us. Similarly, there's a reduction in access to endoscopy nationally in COVID times. So we're all faced with a reduction in both access to pulmonary function tests and a reduction in access to endoscopy from a respiratory. As a consequence of this, we're doing a lot more remote consultations, and there's going to be a larger drive towards remote pulmonary rehabilitation. What's going to happen with these post-COVID syndromes is any person's guess. The HSE and the ITS have come out with some statements in terms of how to manage respiratory disease in COVID times, and they said that patients should continue to take the regular preventer inhalers and all other inhalers as prescribed, should continue to use action plans and communication cards. The use of action plans is recommended, and the prompt treatment of exacerbations. You can still use home non-invasive ventilation, airflow and humidified oxygen. Patients are on regular azithromycin, should continue to use these unless the clinician feels there's another alternative. And long-term steroids should continue to take their medications unless advised to discontinue by their physician. These are just the resources and action plans I mentioned, specifically the last one, a guidance for the clinical management of COPD and COVID and asthma. Some tips we're recommending that people should have rescue packs at home. If patient is dependent on a nebulizer, can continue to use, but assume increased transmission risk. Advise patients to wipe down COPD equipment such as spacers and nebulizers after use. And GOLD is not aware of any evidence to support that inhaled or oral corticosteroids should be avoided in COPD during the COVID epidemic. So in summary, you should consider COPD even in non-smokers. Review the risk factors for somebody, meaning that anywhere between 30 and 80%, depending on your patient and their heritage, can be at risk of COPD even in the absence of smoking. Regular exercise is important, appropriate inhaler medication and risk stratification, particularly using the apps. We're all aware of the national vaccination policies. Weight management is important. Too high or too low is associated with worse outcomes. Intrinsically, COPD patients have an increased risk of anxiety and depression, both as cause and consequence of their disease, and pulmonary rehabilitation should be considered, and if possible, if you can gain access to online pulmonary rehabilitation resources, it may reduce the frequency of exacerbations and hospitalized admission rates. And we're all well aware we're going to be short of beds in hospital this coming winter, so anything that can gain beds is good. If it were not for the great variability amongst individuals, medicine might as well be a science and not an art. And what I'm referring to there is that you have a lot of discretion in managing COPD as to what you think is the most appropriate inhaler, because essentially you're trying to work out the individualized risk of pneumonia, the subjective risk in terms of dyspnea and severity, how likely are they to benefit from an individualized inhaler therapy, and actually trying to put them on a spectrum of risk of pneumonia versus risk of dyspnea versus risk of acute exacerbation of COPD, and trying to figure out where their serum eosinophil level falls into that spectrum. Thanks very much for your time.
Oisin, thank you very much for that talk. I found it really, really interesting and stimulating. And I have to say, every time I listen to a talk on COPD, and particularly your talk, I come away with some new knowledge. It's a topic that you always feel that you're familiar with, but each time I learn new things about it, and that's a reflection on your skill and your talk. So thanks very much for that talk. We have a number of questions that have been submitted, and if it's okay with you, I might just go through a number of them, because some relate to COPD and some relate to COVID, obviously. One of the first questions that came in was about non-invasive ventilation in terms of what is it and compared to home oxygen. So maybe you might just talk a little bit about that.
Yeah, thanks very much, John, and thanks for allowing me to present. As you mentioned, we're kind of, I suppose, phenotyping COPD a little bit better at the moment, and we're looking at distinct subtypes. Now, just to give a quick recap, the lung has two primary functions. It's allow oxygen in and allow carbon dioxide out. And sometimes when I'm giving talks on the lung, I describe the lung as being like a sponge. And if you've got a big soggy sponge, that's like heart failure. If you've a dry, hard sponge, that's like pulmonary fibrosis. And you've kind of a hyperinflated, non-compliant sponge, you can't ventilate well. Ventilation is the movement of gas from the space inside your lungs to the space outside your mouth. And essentially, carbon dioxide diffuses across the alveolar capillary interface 20 times easier than oxygen diffuses in. So you get very quick equilibration between carbon dioxide in the bloodstream and in the alveolar sacs. But what you don't get if you've got non-compliant lung is you get poor equilibration between the carbon dioxide in your alveoli and in the space outside your mouth. So that means you've got poor ventilation. Now, the problem with COPD is you get poorly compliant lung, it's hyperinflated, and in the end stage you get a buildup of carbon dioxide, and that has a number of other consequences, including the fact that when your lung is that destructed, it is a sign that you have static lung, you got mucus retention, and you expectorate poorly. So what non-invasive ventilation is, I suppose it's a broad term encompassing CPAP and BiPAP. We never use CPAP for COPD anymore, we only use BiPAP. BiPAP stands for biphasic positive airway pressure. So it means that when you're taking a breath in, the NIV machine senses the trigger of a breath in, and it gives you one pressure, and when you're breathing out against resistance, so that the small pipes leading into the spongy lung tissue don't collapse and cause mucus retention. It's actually remarkably easy to set somebody up at home on BiPAP for a respiratory consultant. So it's literally, we fill out a form, the reps from, there's 5 companies, I think, in the Munster region, kind of ResMed, PI, Auriga Systems, Air Liquide, they all have home BiPAP. It's literally just fill out a prescription, the rep goes out, sets you up at home, and this is only indicated for your decompensated type 2 COPD patients, so those that have been admitted to hospital with raised carbon dioxide and low pH secondary to a COPD exacerbation. But it significantly reduces the time to their next, increases the time to their next exacerbation and increases the time threefold to their next hospitalization and improves their survival. So we mainly use it at night. It holds true for a lot of end-stage lung disease. So a lot of end-stage cystic fibrosis would have it, motor neuron disease patients will have it, and there's different types of machines and there's different settings. But essentially you're going to be looking at a machine like with kind of an EPAP of 7 and an IPAP of around 14, give or take 1 or 2. So EPAP, expiratory pressure, IPAP, inspiratory pressure, the pressure that the machine pushes in through your mouth into your lungs when you're taking a breath in. Does that answer it?
Yeah, absolutely. Yeah, no, thank you for that. The next question then was just, you comment there on steroid dosage and sort of a pulse dose of steroids, and in terms of the length of time. Somebody asked about, is there any benefit in tapering steroid dosages now, or should we just be aiming for more of a pulse dose of steroids?
Personally, I taper myself. I think the data is equivocal on it. I suppose it's shortish durations. I think, getting back to the phenotyping, there's asthma, there's COPD, and there's asthma-COPD overlap syndrome, and your airway eosinophils, or if you don't have any marker of your airway eosinophils, your peripheral blood eosinophils is very good at distinguishing the subtypes. So I often kind of keep in my mind, how atopic is this patient based on their IgE, what is their bloodstream eosinophil levels, and then I put them on a mental spectrum of, are they asthma COPD overlap syndrome, or are they COPD? If I think they're a true COPD exacerbation with low atopic features, then what's called the REDUCE study suggests that short durations of 5 days is as effective as 7 or 14 days. It gets back to the nuances that you need to mentally phenotype them into are they asthma COPD overlap, or are they COPD, because there is a lot of variation, and I suppose I mentioned it a few times in the talk about this asthma, the Severe Asthma Research Program, they're called the SARP group, phenotyped 5 types of asthma, of which 2 of them were known as obstructive asthma, so that was phenotype 4 and 5. So you can have very similar looking patients with very similar looking FEV1s and FEV1 to FVC ratios, but it's trying to figure out where they are. What I often say when I'm talking or giving talks on lung diseases, if you think of the lung as a series of pipes leading into balloons, what COPD is like the balloons are in a grape type pattern, and half the balloons have been taken away and the residual balloons expand into their space. In asthma, it's the same concept of the same pipes going into balloons in a grape-like pattern, but you have the same number of balloons. The balloons are just inflated or distended. The reason that becomes important is if you've got full pulmonary function tests with a DLCO, there is a remarkable correlation between the amount of lost alveoli on your COPD patient and a reduction in your DLCO. So if your FEV1 is down by 50%, you would expect in a COPD patient that your drop in DLCO, diffusion capacity for carbon monoxide, will be down about 50%. The same obstructive asthma patient will have an FEV1 drop of 50%, but their DLCO will be completely normal. So there is not a proportional drop in their DLCO. So having full pulmonary function tests, and I appreciate that this is extremely difficult in COVID times, but it doesn't change hugely dynamically over time, meaning your pulmonary function tests 5 years ago and your DLCO 5 years ago are relatively static over kind of a 5-year period. So you don't necessarily have to be doing this regularly, but if you're trying to distinguish, is this more an asthma patient or is this more a COPD patient? Because we all have those patients that we say, no, actually this patient needs 6 weeks of steroids, but they're behaving more like an atopic asthma or an obstructive asthma type patient, and we manage them more towards the GINA guidelines than the GOLD guidelines, whereas the more true COPD patient, we're going for less steroids. But as I say, trying to phenotype them accurately from the get-go helps a lot in those decisions.
Yeah, thanks, Oisín. And just putting on your public health hat there, Oisín, we got a question in regarding the recent banning of smoky coal in a number of small towns. If you look, I have to admit this is my question. If you look at one of your earlier slides, you can see the rate of COPD is more concentrated in the cities and less in the rural areas. Do you think we should just ban it nationally?
I must say I do like my regular coal fires and my turf fires, but I suppose from a pulmonary perspective, yes, there is a public health benefit to smokeless fuels, and relatively speaking, in high socioeconomic countries like Ireland, where there tends to be well-designed ventilation, the impact is lower. But similarly, the effects that kind of coal and kind of modern fuels or old fossil fuels has on the kind of causation of obstructive airways disease is actually remarkably high. So it kind of as you say, one of your earlier slides, a comment on that actually in lower socioeconomic countries, and there was a very good kind of graph showing that in some low socioeconomic countries, only 20% of obstructive airways disease is from smoking, and the rest is from other ambient air quality, meaning particulate matter, ozone quality, air pollution. So that is a larger effect in correlating with your kind of economic activity. So I think it's going to be a controversial one because we do love our fires as we grew up with them, but I think from a lung perspective, yes, there will be benefit.
Okay. And then I suppose just turning to COVID, Oisin, and I suppose we're all living in a very changed world, and there's been a number of questions just about, I suppose, the winter ahead, and there's naturally concern about it in terms of our winter readiness and how in general practice is going to cope if there's an increase, say, in flus and COPDs and then on top of COVID, but also how the hospitals are going to be winter ready. Finally, could you just maybe just comment on that and just any suggestions or things that you think we should be doing in terms over the next few months, more so than we're already doing?
I would share similar concerns. I suppose the positives coming out of the Southern Hemisphere are that there was a 95% reduction in flu in absolute terms. So there was, for every 20 infections in years gone by, there was only one this year. So that's remarkably impressive effects on social distancing, hand hygiene. I suppose the difficulty is that 20-fold reduction happened at a time that lockdowns were also occurring, so it's hard to quantify, was it because of lockdown or if the mask and social distancing alone correlate. And I suppose this is being confounded by the fact that the schools are back and pubs are open, so it's going to be very difficult to know what the effect on flu is. From my perspective, the biggest problem we have in Ireland is the scale of test and trace and turnaround and the reserve capacity in this. And I think we are essentially maxed out at the moment. And I think where nationally we may be missing a trick is actually, I think the Department of Health have thought of this in terms of percentages, not scale. And they say, right, we'll put 20% more test and tracers in, instead of saying we need a 5-fold increase in test and trace capacity. We need, 25,000 tests per day. Like New Zealand, when they had their single outbreak, were doing 24,000 tests a day. The most Ireland has ever done is 13,000 tests a day, and the turnaround is too low. And I think from a health advocacy perspective, we all have to be pushing the consistent message that if we don't have adequate test, trace, isolate and speed of turnover, the speed of resurgence of COVID is incredibly dramatic. I think if you look at the data coming out between Madrid and New York, one of the most staggering things between the fact that New York is keeping a plateau at the moment and keeping a very good control, and Madrid has reached the same level as before their first lockdown. It was all down to test and trace, speed and turnaround. So we need to all advocate to our politicians, Department of Health. They need to be thinking on terms of scale and not in terms of 5 to 10% increase, which they classically do. So we need to be saying, no, you need to increase scale 4-fold, not 10%. I think where that's going to affect all of us is a lot of us have been at capacity for about 2 months, and if anything, I think burnout's been starting to creep in as an issue. I think all of us find, or certainly in the hospital environment, we're all saying when we come home from a day wearing masks, we're all wrecked, we're all tired, we're all crankier, more irritable. And if one of my neurology colleagues pointed out, if you think of Parkinson's patients and they've got a mask like fascies, one of the things they complain about is the loss of social interaction when people can't see your face. And Parkinson's patients first complained about that in the mask-like fasciitis, but I think that has led to less kind of emotional interaction with our patients when we're wearing a mask, and we're all a little bit more irritable. So I think probably increasing social interactions, having plans for what you can do, and having outlets outside work. I think burnout is going to be a huge issue for all of us over winter unless we can come with good, healthy ways around it and try to avoid going to the pubs and getting exercise in. So I think we're in for a tough winter, and I don't think there's any way to make that any more pleasant than it's going to be, other than advocating for more rapid turnaround times. I think everyone's done Trojan work in terms of resetting their practices to how to get on with this. Personally, I use a thing called an Envo mask, ENVO. I found them one of the most comfortable masks to use in clinic, and they've got a very comfortable silicone interface and a very comfortable like basically replaceable filter, but making sure you've got good PPE supplies and comfortable ones that work for you are worth considering.
Good, thanks. And Oisin, can I just add one additional question before we finish? Someone's just asked about rescue packs for GPs. A lot of GPs were asked by patients about having a rescue pack in terms of antibiotics and steroids, just in case. And could you just maybe comment on that, because I know some colleagues have had those requests.
There is no evidence behind rescue packs, and it does seem to reduce hospitalizations. I think I'm remembering one figure correctly that for each 17 rescue packs given out, it will prevent one hospitalization. Some people say use the anti-niacin criteria. Anti-niacin wrote a paper on COPD, and he talked about if you have 2 of 3 of change in sputum volume, change in sputum color, and increased breathlessness, you initiate your rescue pack. So you start your antibiotics and steroids. Again, I would say the steroids is dependent on if they've had steroids before and that they haven't had any kind of problems with them. But I think there's no problems or there's very limited side effects. Personally, I give doxycycline and prednisolone. I think there's a little bit of personal choice. I personally found doxycycline to have low side effects. The nuances being women in childbearing age, you wouldn't give them doxycycline, but I found it causes less side effects, and it actually has pretty good cover for Haemophilus influenza, which is one of the most commonest organisms causing COPD exacerbations.
That's great. Oisin, I just want to thank you again. That was very useful. It's as the winter approaches, I think having that refreshing of COPD, I think is benefit to us all. And just to say, mind yourself over the course of the winter. Thank you very much again.
Thank you, John. Have a good one. Bye, guys.
Our next speaker is Dr. Karina Sadler. Karina is an infectious disease consultant in Cork University Hospital and has a special interest in vaccinations and sits on the National Immunisation Committee. So she's going to speak about the emerging vaccination programs that are currently undergo, of which there are many, and I suppose what's the most likely potential for a vaccine. So I'd like to thank Karina for taking the time to speak to us today.
Hello, and thank you for the invitation to speak today. Karina Sadler is my name. I'm a consultant in infectious diseases and clinical lead for COVID-19 at Cork University Hospital. My talk today is going to focus, I suppose, on the progress that has been made to date in relation to a COVID-19 vaccine. Unfortunately, there is no easy out to this pandemic. There's been a lot of talk, both nationally and internationally, about the optimal strategy in terms of tackling the COVID pandemic. So we've heard about suppression, elimination, herd immunity. I think it's apparent to most of us that we're going to be living alongside this very contagious and potentially very dangerous virus for the foreseeable future. And that is really until we identify a safe and effective vaccine or an effective treatment. And I think realistically at this point, most of our hopes lie with a vaccine. And really, as I said, my talk today is going to focus on the progress we've made in relation to a COVID vaccine and looking at the timelines. So the concept of vaccination is one that we're all very familiar with. Vaccines essentially aim to elicit an immune response in the body to an antigen which doesn't cause disease but which stimulates the immune system and it allows it to block or kill the virus or a pathogen if a person does become exposed or infected. And vaccines are generally made up of two components. You have an adjuvant, which is kind of like a danger signal. It stimulates the immune response in combination with a specific antigen, and this acts as the specific target for your immune system. And vaccines essentially provoke two types of responses. There's the antibody response, where primed antibodies, they bind to the surface of the virus or pathogen and they actually prevent cells from becoming infected. The T cell response then is where T cells are primed by a vaccine to identify and kill cells that have become infected with a virus or pathogen. So to design an effective vaccine, you need to understand the pathogen that you're dealing with. The genetic sequence for SARS-CoV-2 was identified very early on in the pandemic in China back in early January. And we know that SARS-CoV-2 is an RNA virus. Usually RNA viruses have a very high level of mutation, but thankfully SARS-CoV-2 appears to have a more moderate rate of mutation, meaning it should be susceptible to a vaccine. And SARS-CoV-2 is covered by these very unique spike proteins, and these proteins bind to angiotensin converting enzyme 2 molecules on the surface of the lung. And it's these specific spike proteins that are the molecule that most researchers are looking at in terms of an antigen and stimulating a specific target or response with a vaccine. As I said, in terms of where we are with the vaccine, the effort, I suppose, to develop an effective vaccine really have been global, and there's been a huge amount of international collaboration. The genetic sequence for SARS-CoV-2 is actually very similar to two other coronaviruses. So SARS from back in 2003, it's about 79% identical to SARS, and it's about 50% identical to MERS, which was around in 2012. So researchers who had worked on SARS vaccines and MERS vaccines had quite a significant head start in terms of background clinical information, and they've pivoted a lot of this work to develop SARS-CoV-2 vaccine candidates. Similarly, a lot of researchers working on viral vaccines such as dengue, Zika, flu have adapted that knowledge in terms of developing SARS-CoV-2 vaccine candidates. And currently there are more than 170 COVID-19 vaccine candidates in preclinical trials, so being developed by over 80 research teams globally. There are 37 vaccine candidates now that have entered human trials. There are 24 in phase 1 trials, so these are traditionally small safety and dose adjusting trials. There are 14 vaccines then that have moved to phase 2 trials. So these are generally, I suppose, expanded safety trials. And there are 9 vaccines that have entered phase 3 or clinical efficacy trials. There are 3 vaccines that have undergone, I suppose, emergency pandemic approval and have been approved for limited use, 1 in Russia and 2 in China. Although this approach hasn't been endorsed or isn't backed by regulatory bodies such as the WHO. And I suppose really the speed at which vaccine development has progressed is phenomenal. Vaccine development is usually, a very slow process. We'll say if we look at the HPV vaccine, from research to licensing of that vaccine, it took over 15 years. So the standard timeline is quite slow. Under what we call the accelerated COVID vaccine development timeline or pandemic development timeline, some of the usual phases, so preclinical phase 1 and phase 2 clinical trials, are actually being run in parallel to speed the process up. And researchers have suggested that they will have efficacy data and will have a safe and potentially effective vaccine ready in between 12 and 18 months, which is phenomenal, as I said. I suppose the WHO have cautioned against rushing any of the regulatory steps, so that they're quite adamant that we need to know the vaccine is not just effective, but it's safe as well. A number of regulatory bodies, such as the FDA, have indicated that they will consider approving a COVID-19 vaccine under these accelerated terms if 50% efficacy was demonstrated in the absence of any significant safety concerns. So in terms of the vaccine candidates that they're looking at, there are at least 8 different types of vaccine being developed against COVID-19, and they each act or rely on different viruses or virus parts. It's really important that they're looking at more than one vaccine type, because we really don't know which one, if any, of these vaccine types will be effective. There are about 7 groups internationally working on virus vaccines, and with viral vaccines they use a weakened or an activated form of the actual virus, so of SARS-CoV-2. And many of the existing vaccines that we have work in this way. So, for example, measles vaccine, where I suppose you have a weakened live vaccine, the polio vaccine also. But I suppose because these vaccines are using an inactivated or weakened form of the actual virus, they'll require really extensive safety testing. That said, Sinovac, which is a biotech company in Beijing, have a phase 3 clinical trial on an activated SARS-CoV-2 virus, Coronavac, and the Chinese government has given an emergency approval for this vaccine, and they're projecting that they'll be manufacturing it in large scale and will be ready to use it in March 2021, so in early 2021 at a large population level. Viral vector vaccines then, these vaccines essentially use replicating a non-replicating virus, and there are about 25 groups internationally, including, I suppose, the Oxford group and the China group, working on viral vector vaccines. And this is essentially where a virus such as the chimpanzee adenovirus is attenuated or modified, so it can't cause disease in humans. And beyond that, it's further modified so it will produce the specific spike proteins from the SARS-CoV-2 virus to stimulate a specific immune response, which they hope will be effective. And again, a number of viral vector vaccines, so particularly the Oxford group, have a large phase 3 clinical trial underway. They're enrolling 10,000 participants in the UK, and beyond this they'll be enrolling participants in Brazil, the States, South Africa, where I suppose the rates of infection are higher, and they're projecting that they'll have efficacy data available by the end of this year. Nucleic acid vaccines, including DNA and RNA vaccines. These are a new type of vaccine. There are at least 20 teams, including the Moderna group in the US and Inovio, and these groups are aiming to use genetic instruction in the form of DNA or RNA for a coronavirus protein. So again, the spike protein to stimulate an immune response. And finally, protein-based vaccines where you inject protein subunits or virus-like particles which mimic SARS-CoV-2 directly to stimulate immune response. And again, this is a model of vaccine that we're familiar with. So the whooping cough or pertussis vaccine, hepatitis B, HPV vaccine would use this model. And just to mention briefly, there are other trials. So there was a lot of talk initially about the BCG vaccine that's entered clinical trial now. Similarly, the polio vaccine, and they're looking at whether these vaccines, by stimulating a general immune response, rather than stimulating adaptive immunity, can offer some protection at a population level from SARS-CoV-2. So I think it's important to mention funding. So there's a huge amount of funding going into COVID vaccine internationally. And while there has been a huge amount of public and non-profit funding invested globally to support this research, over 70% of the groups leading vaccine research are funded through industry or private firms. And I suppose partnership with industry will be hugely important, not just, I suppose, in discovery or research into the vaccine, but also to manufacture the, I suppose, numbers of vaccines that we'll need on a global level. There's going to be huge partnership needed there. And the situation hopefully may arise where we have more than one potential vaccine candidate being developed by more than one country in the world. So briefly, just to look in more detail at some of the front runners in terms of vaccine development. In early July, there was a study published in the New England Journal of Medicine. This was a study run by the US government, National Institute of Allergy and Infectious Diseases, in partnership with the Moderna group. And they looked at the mRNA 1273 vaccine. And essentially they found a very robust immune response, so a robust antibody response without any significant safety concerns. Again, it was a phase 1 trial. It was a small study, 45 healthy adults recruited. But as I said, this is one of the groups who are progressing a phase 3 clinical trial now. They're hoping to recruit 30,000 individuals in the coming months, and they're optimistic that they will have a positive result and that they will show vaccine efficacy. The Oxford trial then, I suppose, was published in The Lancet in late July, and there was a huge amount of media coverage of this study. This was a combined phase 1, phase 2 clinical trial, which involved over 1,000 healthy adults aged 18 to 55 years. And they used a chimpanzee adenovirus vectored vaccine, which was heavily modified. So I suppose it was unable to cause infection in humans. And they transferred genetic instruction for the coronavirus spike proteins. And they reported a strong antibody as well as a T-cell response with the vaccine. And the Oxford group has similarly progressed to a large phase 3 clinical trial. So they'll be recruiting 10,000 participants in the UK. I suppose as the rates of infection have fallen in the UK, it may take longer for them to, I suppose, prove efficacy, but they have parallel studies running in Brazil, South Africa, and the States, so in areas where the rates of infection are quite high. So they are still optimistic that they will have efficacy data available by the end of the year. And I suppose in parallel with that, they have also, I suppose, agreements for manufacture of the vaccine to be scaled up even at this stage. So if they do demonstrate a clinical efficacy, that they will have a vaccine ready and available to use. The China study was also published in the Lancet in late July. And similarly, this study looked at safety, tolerability and immunogenicity of a very similar recombinant adenotype vectored vaccine. And reassuringly, the results of their study showed that the vaccine stimulated both an antibody and T-cell response, and they didn't find any safety concerns. And this is one of the vaccines in China that has undergone, I suppose, rapid approval, and they are using this vaccine currently in China in military recruits. So this is the most recent study published again in the Lancet last week. This study was published by a group in Russia, and I suppose Russia are the first country to license a COVID vaccine. It's a two-shot or 2 doses of vaccine. They've licensed it for domestic use late last month. So I suppose in terms of the study published was a phase 1, a small scale clinical trial. So it was 2 studies actually, both looking at 38 healthy adults. They didn't report any serious adverse effects, and they reported a robust immune response in both groups. Again, this is an adenovirus vectored based COVID vaccine. And I suppose some experts have cautioned, and I suppose the WHO have cautioned against, I suppose, approving a vaccine until the appropriate regulatory steps have been taken. So I suppose in terms of what remains to be done, I suppose the early published results in terms of immunogenicity are very promising and do offer a glimmer of hope, but there really are no guarantees until we see results of the phase 3 clinical trials. It's really going to be hard to know how effective a vaccine will be in terms of preventing infection, preventing transmission, or mitigating disease severity until we have these results. I suppose beyond the challenge of developing an effective vaccine, even if we had a vaccine early 2021, logistically there'll be a huge challenge in terms of supply and demand. I suppose some experts have projected that we would need 60 to 70% of the population to be immune or to have protection and for us to achieve herd immunity. So we'd be talking about millions of doses of vaccine to be developed, to be distributed, to be administered. So I suppose that there will be a number of challenges beyond developing a vaccine. I suppose there's a lot of conversation around priority groups in terms of there'll be countries competing for a vaccine, and within countries, I suppose, who are the priority groups that we should be looking to vaccinate. I suppose clearly healthcare workers have one of the highest risks of exposure and of infection. I suppose there's also a risk of healthcare workers transmitting SARS-CoV-2 to vulnerable patients. So they'd certainly be a group that would be considered. Similarly, older adults, residents of care facilities, people with comorbidities, so diabetes, obesity, groups that have been shown to be at higher risk of getting complications should they be exposed or infected with COVID-19. There's a huge amount to be considered in terms of this. I suppose if a vaccine does become available, vaccine uptake or coverage with vaccine will become an issue similarly. The WHO have actually listed vaccine hesitancy, and this was prior to COVID-19, as one of the top 10 global public health threats. So should a vaccine become available, clearly there will be groups of people who will be desperate to access the vaccine, but similarly there will be groups of people who are hesitant, who are afraid, or who simply won't want to take the vaccine. And I suppose at a population level, this could be a significant issue as well. Sorry, and I suppose just as we come into flu season, I think it's important that we reflect on our own vaccine coverage nationally. I mean, this data is from 2017, and I'm glad to report that our flu vaccine uptake in the over 65 age group has improved in recent years. It's up to probably above 68%. But if we look at our 18 to 64-year-olds, if we look at risk groups, so pregnant women, people with other comorbidities, vaccine uptake in these groups is really suboptimal. It's down around 30%. If we then look at our flu vaccine in these groups, people with chronic medical conditions, if we look at them in the context of Europe, really, as I said, we're well below par. So I suppose there's a lot that needs to be done from a primary care perspective, from a hospital perspective in terms of improving vaccine coverage. Similarly, I think there'll be a big focus on flu vaccine uptake in healthcare workers as flu vaccine becomes available. And I similarly think it's important that we reflect on not just why patients are not getting vaccinated, but why people do get vaccinated or consider getting vaccinated. And again, this is a study carried out by the HPSC in over 3,000 individuals. And I suppose because a doctor or healthcare professional recommended it, is frequently cited as a reason for people to get vaccines. And I think we all need to consider that in our daily practice. So to finish up, I am hopeful that we will find a COVID vaccine, but I think it's very unlikely that a vaccine is going to make COVID disappear altogether. And unfortunately, I don't think we're going to see an immediate return to normal when we do get a vaccine. I think it's just going to be one additional factor, but one very welcome additional factor in our armament against this virus. Thank you.
Thanks, Karina, very much for that talk. It was really, really good and interesting, and it's just fascinating to see the amount of work that's going into the development of the vaccine or potential vaccines and the challenges, I suppose, that are faced in doing that. We've had a number of questions in with regard to vaccines, and we might maybe just talk about that development first and then maybe go to a few general comments. The first question we've had in is, would people who already had COVID-19 also need to be immunised again?
Yeah, thanks, John. That's a really interesting question, I suppose. We've seen a lot of patients who were admitted in the first wave of COVID-19 with the infection back in our post-COVID clinic, and I suppose the question they all have is, can I get this infection again? I suppose there's a lot of studies that have been done around antibody. We've looked in CUH at antibody levels in healthcare workers who are infected with COVID, and we would find kind of between 80 and 90% will have detectable antibody. I suppose what we don't know, I suppose we can only extrapolate from other studies at the moment, is whether having antibodies means you're immune. I mean, we certainly, there is over 8 cases now in the literature of reports where people have been reinfected with COVID-19. Similarly, I suppose immunity studies that have been done on vaccine would indicate that the immune response to the vaccine would be much higher than the response to actual infection. So my sense is, I mean, we're telling people that they need to continue to take all the precautions that anyone who hasn't had the infection would take, so the hand hygiene, the masks, and the physical distancing, avoiding crowds. My feeling is that people would be, who've had COVID, would be eligible for vaccine. If there's a sense that immunity won't last long, I suppose we don't know if we'll have a vaccine. We don't know how long immunity with a vaccine will last, and I'd imagine they would be triaged into, I suppose, groups, and if they're in a priority group for a vaccine, I imagine that they would be eligible, and the vaccine would be recommended for them. That there's a lot of ifs there, and a lot of unknowns actually. So I suppose we'll almost need to wait until we have more information. But I imagine yes, they would.
Very good, thank you. And you're being tested this morning. And the second question is, how many times has the virus mutated and is likely to mutate further? And how does this affect the vaccine's efficacy?
Yeah, again, that is a really good question. So SARS-CoV-2, it's an RNA virus. We know RNA viruses generally, so the viruses that cause colds and flus generally have a very high rate of mutation, which would mean that it would be very unlikely they would be susceptible to vaccination. They're saying with SARS-CoV-2 that it has a more moderate rate of vaccination, so it is mutating the whole time, but not significantly, and they feel that it will be susceptible to a vaccine. I suppose they are looking at genotyping studies, I suppose, in Ireland and internationally. I suppose we can only hope that, given they're saying it has a moderate rate of mutation, that it will be susceptible to a vaccine. I suppose as the rates of severe COVID infection decreased, and as the curve was flattened, both here and internationally, people were saying, has the virus lost virulence? And that there's no evidence at all that seems to be the case. Is it a milder virus that's circulating now? And again, that doesn't seem to be the case. I think what we were seeing was more a result of behaviour at a community level, and I suppose that's what's going to remain a very important factor going forward.
Very good. Karina, you mentioned there a little bit about post-COVID clinic. Could you maybe expand on that a little bit?
Yes, so we have a kind of a multidisciplinary clinic in CUH where at the moment we're just reviewing our patients who've been admitted with COVID infection. I suppose just like any follow-up clinic, obviously the majority of patients who were admitted were quite unwell. They would have required, I suppose, some level of oxygen therapy. Many of them would have had bilateral pneumonias, and I suppose they've come back just for a routine clinical visit. The clinic is, I suppose, being supported by the ID service, the respiratory service, who actually ran a virtual pulmonary rehab program for these patients when they went home. And similarly, as has been reported internationally, I suppose from a mental health perspective, a lot of people found that they, I suppose, have a lot of anxiety or have ongoing issues in terms of, I suppose, symptoms like fatigue. Some people have ongoing shortness of breath. The recovery appears to be quite long with this infection for about half of patients who seem to have ongoing symptoms. So the liaison psychiatry department are supporting the clinic as well. And there is a research component as well through UCC who will be looking to follow up, I suppose, biomarkers and other things over a 12-month period. So I suppose they are, I suppose, a well-defined group of patients, but they seem to have a very broad spectrum, of ongoing issues. And I suppose as had reported, it doesn't seem to be a viral infection in people who have been unwell and required hospitalisation, where the recovery is rapid. As I said, in our clinic, I'd say about 50% remain out of work and 50% of ongoing debilitating symptoms.
Yeah, that's interesting to know, really, particularly, I suppose, with the road ahead. In terms of the winter, Karina, there's a big push for the flu vaccine, which is starting very shortly, and we're vaccinating children for the first time, I suppose, this year. Can you just maybe expand on the logic of why there's such a big push for the flu vaccine and the logic of expanding the vaccinations to children, wearing your national immunisation hat, I suppose?
Yeah, I think flu vaccine could be extremely important this year. It's important every year. Every year around November, December, coming into January, that the hospitals are overwhelmed with patients admitted with viral pneumonia or bacterial pneumonia secondary to flu. I just even thinking of CUH last year, we'd almost 80 patients with influenza, confirmed influenza, admitted in the hospital in December, and it always impacts elective work. It leads to overcrowding, absences in healthcare workers because they're sick. We know the flu vaccine is effective. It's probably 70% effective in preventing severe illness relating to flu. We know that a lot of children get flu. A lot of children pass flu on to relatives or elderly relatives. So, anything we can do in terms of, I suppose, mitigating the risk of flu, I suppose we would hope that some of the measures that are introduced now in terms of COVID prevention may mean that we have a milder flu season, but certainly where there's a vaccine available, it's very important that people take the vaccine. I suppose, our uptake in the over 65 tends to be good. That programme is well established and well delivered through primary care. I think we certainly need to do a lot of work in relation to healthcare workers, particularly in hospitals, in long stay facilities, in nursing homes, because I suppose it's not just healthcare worker absences. We're all very aware now that people can have very mild illness or be asymptomatic carriers of viral infections, and they can have very severe consequences in vulnerable groups. So the other group I think it's very important to target and consider are the kind of 18 to 65-year-olds who don't fall in that kind of automatically vaccinate the over 65, and they often don't consider themselves at risk, but every year we do see young people with underlying conditions or even healthy young people admitted with severe complications from influenza. So I think that the flu vaccine for children, I think it's a really it's a really good thing, but I think it's unclear as yet as to how it will be delivered and how it can be delivered to the levels we'd want to have it delivered at. And I know the National Immunisation Office are probably linking with primary care and trying to agree a mechanism for the widespread delivery, hopefully, of flu vaccine, because there won't be time this year to have it delivered through a school programme.
Yeah, no, that's a good point, and it's a challenge, I think, for all of us. And then finally, Karina, maybe just looking into a crystal ball, if you can, what do you think the timeline for an effective vaccine, if we do get one, realistically will be? And also then, how do you think we're going to do in terms of hospitals and nationally over the winter?
Yeah, I think, as I said, the front runner, which was the Oxford vaccine, that study has been paused this week because of I suppose a potential severe adverse event which they're investigating. So AstraZeneca have started the manufacturing of millions of doses of this vaccine. They expect it to have efficacy data available by December. In a way, it's reassuring that they have paused the study and that they are following all the safety regulations, but until that is fully investigated, all those doses of vaccines will be binned if this is a severe safety concern around this vaccine, which, as I said, is the front runner. I think the earliest we'll see efficacy data is probably December, January. Now, lots of industry, or there's partnership with industry, so they are actually developing millions of doses of these phase 3 vaccines as we speak. So I would say kind of midway through 2021 we probably would be looking at vaccines being available for priority groups, but I think similar to what happened around the time of H1N1 is they'll need to triage priority groups as the vaccine becomes available. So whether they'll deem, healthcare workers who are at risk of exposure and infection and then passing the infection on to vulnerable patients themselves and people that have risk factors for the disease. All these protocols will be in place, and then again there'll be a huge issue around making the billions of doses that will be required internationally. There'll be competition between countries. I suppose we'll be part of the European group in terms of buying vaccine doses, and then at a national level how the vaccine can be administered quickly. But we have had, I suppose, experience during H1N1 and vaccine was delivered very quickly, so that there will be a template there. I suppose in relation to how the hospitals will do coming into winter, I mean, capacity in hospitals is a big issue at the moment. We have trolleys every day, which aren't in the emergency department as such. They're distributed in rooms adjacent to the emergency department. This is in CUHs in hospitals across the country. We're not in a surge from COVID. We're not in a surge from flu. The hospitals come under severe pressure every year with flu. As I said, we had a particularly bad year from flu last year. So I suppose there are lots of variables in terms of if we start to see a surge in COVID, if we see lots of flu cases. It's really about capacity and beds in the hospital, and I suppose none of us want to go back to a scenario where elective work is cancelled, or where I suppose routine care, which is so important for patients, is not going ahead. So I suppose I would say, there's a lot of anxiety and apprehension in the health service about how we will cope, and unfortunately, one would need a crystal ball, but we are expecting it to be busy and for the system to come under a lot of stress.
Great. Queena, I just want to thank you for taking the time this morning, just giving us an insight into some of the challenges of the vaccine, and it's just very good to get sort of the hard data and science behind it. So it's very much appreciated, and also the work that you do on the National Immunisation Committee. So thank you very much for those insights and for your time. Thank you.
Thank you. Yeah. Bye now.
Bye. Our next speaker is Nicola McNamara, and because it's such a lovely morning today, certainly in Cork, and all mornings in Cork are lovely, we're going to continue, and because I know people at home will probably be just having coffee while watching this, so we're going to continue on and not have a formal break. And so I'm going to hand you over to Nicola now, who's just going to maybe say a few words about the COPD and cardiovascular product overview.
Hello everyone, my name is Nicola McNamara and I'm a medical representative with A. Menarini Ireland Pharmaceuticals. I'm working in the Cork, Kerry and Waterford area. I would like to speak to you today briefly about three of our key products: Brimika Genuair, Eclira Genuair for COPD and Renexa for angina. Firstly, Brimika and Eclira. Eclira is our LAMA, long-acting muscarinic antagonist, indicated as a maintenance bronchodilator treatment to relieve symptoms in adults with COPD. Eclira can be used as an initial treatment as per the GOLD and ICGP guidelines or in combination with an ICS-LABA. Brimika is our LAMA-LABA, long-acting muscarinic antagonist and long-acting beta-2 agonist. Brimika can be used as per the GOLD and ICGP guidelines as a step-up therapy from any LAMA or LABA, or as an alternative treatment to any LABA ICS, or as an alternative to any other LAMA LABA. Both Brimika and Eclira are delivered via the Genuair device, which I am now going to show you. This is pre-filled and ready to use. It is the only pre-filled device that has two mechanisms of feedback, both auditory and visual. It has a threshold trigger mechanism to prevent accidental double dosing. It has a lockout mechanism to prevent further use once the last dose has been delivered. The Genuair device works as follows. Hold the inhaler horizontally, press and release. The control window will go from red to green. The patient should exhale fully away from the inhaler, ensuring never to blow directly into the mouthpiece. Hold the inhaler horizontally and breathe deeply through the inhaler. The patient should listen for the click, which ensures that they have taken the dose. They should inhale for as long as possible after they hear the click. Use the control window to ensure that you have taken the dose correctly, i.e. the window has gone back to red. Take the inhaler out of your mouth and hold your breath for as long as is comfortable to do so. Slowly breathe away from the inhaler. For further information on the Genuair inhaler, please visit www.genuair.com. In summary, Brimmica and Eclaira both provide significant reductions in nighttime and daytime symptoms versus placebo. Both are contained in the Genuair device, which is easy to use. Both are BD dosing. Brimmica has the added benefit of containing formoterol, which provides rapid bronchodilation within 5 minutes of dosing, which is sustained and clinically meaningful. For further prescribing information on both Brimmica and Eclaira, please visit medicines.ie to review the SMPCs. As part of Menarini's cardiovascular range, we offer Ranexa or ranolazine. Ranexa is indicated for adults as an add-on therapy for the symptomatic treatment of patients with stable angina pectoris who are not adequately controlled or intolerant of other first-line antianginals such as beta blockers and/or calcium channel blockers. Clinical studies have shown that Ranexa significantly improves exercise duration, significantly reduces nitrate use and angina attacks, does not significantly affect BP or heart rate, and is generally well tolerated. Ranexa is available in 3 doses, 375 mg BD, 500 mg BD, and 750 mg BD. 375 mg BD is the recommended initiation dose, and it is recommended that this should be titrated up to 500 mg BD after 2 to 4 weeks. Should it be required, according to patient response, this can be further titrated to 750 mg BD maximum dose. Ranexa has a number of contraindications which can be seen here. On behalf of A. Menarini, I would like to thank you again for your time and thank you for joining us here today. For full prescribing information for Brimmica, Eclaira and Ranexa, please refer to the SMPCs on medicine.ie.
Thanks, Nicola. Thank you very much for that, and it is much appreciated. Our final speaker this morning is James Dollard. James is a cardiologist in the Mater here in Cork, and prior to taking up his position in the Mater, he was a cardiologist and internal physician in the Mercy Hospital. So he knows Cork well and provides an excellent service and is very helpful and supportive. James is going to talk about the COVID period and also the management of the cardiological complications of COVID. This is an area I think that is certainly evolving, and I know many of you have come across patients who've experienced some of the complications post-COVID, and I think we're going to be learning and seeing an awful lot more of some of these challenges, and certainly the literature that's coming out is highlighting this as a concern. So I think it's a very timely talk this morning. So I'd like to thank James for his talk this morning.
Thank you very much. My name is James Dollard. I'm a consultant cardiologist and general physician working in the Mater, and I've been invited today to talk about cardiology during COVID. So obviously very challenging times for us all. We've had to adapt and change how we're doing everything. Patients have adapted what they're doing too, and they've been exposing themselves to lots of risks indirectly through that by not accessing usual hospital care. And the management of chronic conditions rather is going to fall on general practitioners even more so during the COVID era, as people are more reluctant to come to hospital. So we've seen a lot of changes in how healthcare is accessed even at the moment. There were reductions in presentations with MIs in the UK by almost a half. We're not sure if there were just fewer MIs because people during lockdown were taking care of themselves, or if just people weren't presenting to hospital with their MIs. I'm sure there's a bit of both, but certainly patients, when they're left to their own devices and their own fears, won't seek care when they need it. So they need to be encouraged to do that, but we also need to make it as safe as possible. So what I'm going to be talking about today really is just about COVID and the heart, because there's certainly an interaction there, an interplay. And we really need to focus on what's important for the outpatient versus the inpatient. You're primarily going to be looking in primary care at outpatient things, and obviously elderly patients not wanting to come into the practice, you're going to have to improve the virtual clinic scenario as well, which we've tried to do in the hospitals to the best of our ability. Quite challenging, quite limited at present, but hopefully we can capitalise on whatever we practice now for the future, because it's certainly a very useful way of doing things. And then finally, for the last little bit of the talk, we're going to just talk about managing those diseases that you're going to have to manage in the community. So one of the primary things that we're going to be looking at throughout all this, there's the European Society of Cardiology have basically a guideline available for you to look at. They've gone through all the evidence. It's updated quite often. They're very stringent in what they put in there. They won't put any rumour or speculation, but they are quite circumspect about several aspects. So it's supposed incumbent on us all to just keep ourselves up to date and to look at everything with a critical eye, because there's lots of bad science being done at the moment. So as I'm sure my other speakers will have gone through already, SARS-CoV-2 or coronavirus 2 causes a viral pneumonia as its primary disease. It affects endothelial, epithelial cells in the heart, the vasculature, the lungs, the kidneys, the gastrointestinal tract. It's a multi-system disease. And I suppose when we heard from it coming from China first, they found that the patients who were in the hospitals and dying tended to be older patients with cardiovascular comorbidities primarily. And I suppose that observational data coming out at the start, people tried to link the dots, join the dots, and they were wondering, were these cardiovascular diseases causative to bad outcomes? Were you more predisposed to actually getting coronavirus? And then if you got it, were you more predisposed to dying because of it, because of cardiovascular comorbidities? So we'll try and deal with that a little bit. But certainly it is true that people who die from coronavirus or COVID-19, they tend to be people with clusters of cardiovascular risk factors and people with cardiovascular backgrounds. And then patients who may or may not have cardiovascular problems in the background, they can develop cardiovascular issues because of coronavirus. So in patients, they can get plaque rupture giving them MIs, they can get PEs, you can get myocarditis and resultant heart failure, and then a whole plethora of arrhythmias, atrial fibrillation up to VT, both from treatment and from the disease itself. So to get to the numbers, the risk factor prevalence, so it was older patients with hypertension primarily in China, and when they got to the US, when there was the big outbreak in New York, they started to do a lot of observational studies there, and they found that yes, hypertension was overrepresented in that population. So you could see 57% versus about 45% in the general population. A lot of the patients were obese, but a lot of Americans are obese, and it didn't seem to be disproportionately present. Diabetes certainly were overrepresented too, and then there was a smattering of coronary artery disease and heart failure. So again, what the ESC's position on all of this, these risk factors, is that it's probably a confounder, that sicker, older patients tend to get sicker with COVID, they tend to end up in hospital and they tend to die. You could have probably said that at the very start if you were guessing. In the UK, they found that ethnic minorities, black people, Asians, Asian extraction, they tended to do worse. So whether that's socioeconomic or genetic epiphenomena, we don't know. But the facts are that they do worse than the white population. And this is a study just that came out in Nature, I think a month and a half ago. Again, an epidemiological study looking at 17 million patients, really the primary care data from the UK, and they had about 10,000 deaths to look at, and they tried to see what makes these people different to the general population. And it's all the things you'd expect. They're older, they're men. That was something. Men and women get coronavirus just about equally, but the men tend to do worse. And then if you're more obese, you're more likely to do poorly. If you've got an organ transplant, if you're on immunomodulatory therapy, all these things affect us. All kind of common sense things. So what are the manifestations cardiovascularly of coronavirus itself? Well, we know from the first SARS and then MERS that coronaviruses can cause cardiovascular issues. The SARS caused problems with diastolic dysfunction, a little bit of myocardial injury, and then MERS was associated with myocarditis and heart failure. So we're just trying to find out what exactly is going to happen with SARS-CoV-2, and certainly autopsy data has shown that there is a strong inflammatory response inside the cardiomyocytes. When they did autopsies and biopsies, they found that there were certainly lots of mononuclear inflammatory cells inside the heart, that there probably was active inflammation there. And then only recently have they actually been able to isolate viral or virion particles with just PCR, but it did require an awful lot of replication cycles to actually amplify that signal. So there doesn't appear to be a fulminant virus inside the cardiomyocytes, but certainly it can lead to cardiomyocyte issues. One of the things they've also found in the studies would be that if you have myocardial injury, which basically means a troponin rise, you do worse, and that stands to reason as well. We've known that elevated troponins are a poor prognostic feature in lots of conditions. So you've heard of demand ischemia, type 2 MIs, when somebody's in with septicemia, they'll have a troponin leak, we call it. And there's been no disruption to the blood vessels, the heart's been under pressure. Physiologically, everything's under pressure and the troponin just leaks out. So you're 4 times more likely to die if you have a myocardial injury with COVID. So it stands to reason again. So we're wondering, should we be using this as a prognostic marker in admitted patients? About 7% of people hospitalised and who survive will have a troponin rise, but people who do poorly and die, up to 73% of them would have a troponin leak. So we don't know the long-term data. We have no idea if we're going to be left with loads of people with heart failure or nothing at all. Time will tell. We're just not sure. But there's lots of ways in which coronavirus can affect the heart. So it enters endothelial cells as well as epithelial cells in the lungs, but endothelial cells in the blood vessel, and it can cause endothelial dysfunction. This can cause microvascular ischemia. It can cause macrovascular disease. You can get direct involvement of the heart muscle itself, giving you this myocarditis. So you can get arrhythmias, heart failure, heart attacks, all of these things. And then, of course, you can have secondary cardiac damage from having a PE. We know that thromboembolic disease is very prevalent in COVID as well. So the pathophysiology is, as again I'm sure you know, the ACE2, angiotensin converting enzyme 2, is the receptor moiety to allow the COVID to get into these epithelial and endothelial cells, and that's widely expressed in multiple organs, but particularly the lungs, the heart and the vasculature. And then the host response, you can get a cytokine response syndrome or a cytokine storm, whereby you get an overexuberant response. This can put pressure on the cardiovascular system, and as I said before, the heart can fail as a result of something else happening elsewhere such as kidney failure or pulmonary failure, etc. So this ACE2, once they found out that this was the mechanism for entry, focus then immediately went to hypertension and ACE inhibitors and ARBs, and this was the big question going through March, April, May. Should we be stopping ACE inhibitors and ARBs in these patients? And the idea was if you're on an ACE or an ARB, you'll upregulate your ACE2. Now, angiotensin converting enzyme 2 is a good thing, and ACE2 breaks down angiotensin 1, which is, if you remember, what actually, angiotensin 1 rather goes to angiotensin 2, and that gets broken down by ACE2. The angiotensin 2 is the bad moiety that we're trying to stop with ACE inhibitors. It causes vasoconstriction, salt retention, myocardial fibrosis, and ACE2 breaks that down. So ACE2 is a good thing. So it's a good thing that the ACE inhibitors upregulate this. But the thinking was, if you've got more ACE2 in these cells, will things go into, will the virus go into the cell more easily? So there was a concern about, should you be stopping these things? And then just last month there was a meta-analysis of everything, and basically it showed that no, if you're on an ACE or an ARB, you don't appear to be more likely to contract COVID-19, and you don't appear to have worse disease. And they actually put this to the test. This just came out. It's not published yet, so you always have to be careful. It came out of the European Society of Cardiology just last weekend, and this was done in Brazil, which, as you know, is having a terrible outbreak that's just only finally slowing down now. And they did a randomized open label trial, so they knew what was going on, but in half the people who came in with hypertension who were on an ACE or an ARB, they stopped their ACE or ARB, and the other half, they let them go ahead with it. And there was no difference at the end of 30 days in terms of who managed to get home and get better. So the ESC advice from the very start was, we don't know. You should continue with the ACE or ARB if somebody's on it for hypertension or heart failure, and all the data that's coming out seems to corroborate that position. So we'd certainly recommend continuing with ACEs or ARBs. Myocarditis and COVID, I know, is a very topical thing, and there was a big paper in JAMA Cardiology about cardiac MRI and coronavirus, and even in asymptomatic people, up to 78% had some finding on their MRI that there was something wrong. And then the Big Ten, the athletics in the colleges and the football in the colleges in the US stopped people basically playing football based on these studies. The reality is that almost certainly COVID will affect the heart. Almost certainly it does cause myocardial injury. It can cause myocarditis. In order for there to be myocarditis, usually the troponin will be elevated, but not always. Very mild inflammation will show up in an MRI. And the question is that actually clinically relevant? We don't know. And we don't think that we need to be doing cardiac MRIs in everybody to look for myocarditis. The thinking would be, if somebody has COVID and they're an athlete, should I stop them exercising? Because if they've got an active myocarditis and they exercise, they might end up getting heart failure. Or even if you're asymptomatic with COVID, will you end up with heart failure 10 years down the line? We don't know. Hopefully not, probably not, but we just don't know yet. So myocarditis is certainly something that we look for in the very sick patients with COVID, but I don't think we need to be overly fearful of it just yet. As in patients, when they have myocarditis, we just do usual care. We bed rest, fluid management, ACEs, beta blockers, things like that, treat the underlying cause, supportive management, and if they go into cardiogenic shock, we deal with that as well. And hopefully these patients will be few and far between in Ireland. So just to give you an idea of what the ESC says we should be doing, I know this is pretty small, but it's just the green thing on the right of the screen is what I want you to focus on. These are things that can just wait. We do lots of procedures in cardiology, and I think it's important for cardiologists to know that we can delay a lot of things. So people with stable angina, you don't need to stent them there and then. They can wait more than 3 months. People with severe aortic stenosis awaiting a TAVI, where their valve area is greater than 0.6 centimetres squared, they can safely wait 3 months. If you're going elective ablations, elective cardiac device implantations, obviously that's fair enough. If you're doing angiography, for example, somebody comes in with a dilated cardiomyopathy, we want to make sure they don't have concomitant coronary artery disease, that can wait for 3 months. And similarly for the EP, the electrophysiology field, primary prevention ICDs can wait, implantable loop recorders can wait. All these things are not urgent. So that's what we've been trying to do. We've been trying to postpone things, but ultimately we're going to have to deal with this. And this is the real second wave that I, as a cardiologist, worry about, is that all these patients who didn't get their appropriate therapy during the 3 months and longer of lockdown, they're going to come back. They're going to need it eventually. And that's why the chronic disease management needs to be just right for the next few months to prevent a tsunami of these patients. So moving on to the virtual clinics, I have to say I enjoy them. We immediately changed back in March from outpatients to virtual clinics. We triaged everybody. New patients do need to be seen. Return patients all went immediately to virtual clinics. There are multiple ways to do it. You can just do it over the phone, which is limited, but certainly a lot of patients prefer that. If people are tech savvy, you can do video conferencing, but that brings its own limitations in terms of data protection and privacy. So whatever works for you and the patient, I suppose, is what needs to be done. And In the US, certainly in terms of privacy and legislation, they gave everybody a free pass for the first few months, but they're tightening up on that now. So we're going to have to really see in Ireland in terms of regulation how this is going to move. But at the moment, this is the way we're doing things. And the clinic is very, very easy. You're in your office, you contact the patient, hopefully they answer. It reduces no-shows. They tend to call back if you miss them. They're in the comfort of their own home. The patient feels like they're a real partner. They're not having to drive all the way in, wait in a waiting room, come in to see you. You contact them on their terms. They tend to like that. They're in their own environment. They may be able to have a sheet of paper or somebody else who's a little bit more tech savvy or somebody who understands the medical parts of it nearby. And certainly I think patients enjoy it. I enjoy it too because it's much faster, really. There are definitely limitations to it though. And I suppose chief amongst the more advanced virtual clinics would be that the patients may not have the infrastructure. We probably don't have the infrastructure for video conferencing with patients. And there's a cost and a privacy and regulatory aspect to that. You can't do a physical examination. You rely on the patient to do that. You might not be able to get a feel for what the patient is thinking, and certainly at the other end of a telephone. You can't do ECGs, urinalysis. There's lots of these things that we need to get over. And in terms of the virtual clinics, the patients are going to have to partake a little bit more actively. They're going to be responsible for doing their vital signs. So lots of people with blood pressure monitors will be able to tell you their average blood pressure, their average heart rate along with that, which is important in heart failure and cardiology. They can have their own thermometer. Some people can buy their own O2 sat probe very easily if they're COPDers and they need this kind of thing. They can keep a weight diary at home. So there's a lot that you can gain. The one thing you can't do, of course, is listen to their heart and lungs, and that's what I find most challenging. But in America now they have USB electronic microphones that the patients can buy, plug it into their computer, put it on their chest, and at the other end you can hear their heart sounds in their lungs. So we'll wait for that to happen. The patient as well can do a mini examination. They can stick their thumb in their leg to show you if they've got edema. I wouldn't be confident trying to say if somebody's got a JVP down a video conference. They can press in on their tummy to see if they've got any pain. They can tell you where they're sore. They can illustrate all of that. But obviously the lack of an examination is a real limitation. But a lot of the time you don't need to do a thorough examination to deal with the patient's problems. So the scope of the clinics in cardiology, we do a lot of the time they've come in for a test and we ring them with the result. They don't need to hang around, and we go through the result over the phone, be it blood tests, stress tests, echoes. General follow-up as well. A lot of the time we're just checking, are the patients compliant with their tablets? Are they getting side effects? Are they getting symptoms? Do they have any questions? All of that can be done down a phone line or a Zoom call. The symptom management, this is where the heart failure clinics come into their own. We've been doing it for ages. The heart failure nurses are there, not quite 24/7 yet, but they're a real point of contact, and the patients will say, my weight has gone up, I am more breathless, what do I do? And we give them advice down the phone without ever seeing them. So this has been happening, and hopefully one of the good byproducts of COVID is that we'll get better at it and patients will be more comfortable with it. Like people working from home, patients might want to access their healthcare from home as well. So finally, moving on to the chronic cardiac conditions, what you can do to manage these cardiac patients at home, because it is very important to treat these to prevent the tsunami of bad outcomes, but also just to protect the patients from not having to come to hospital as often. So we're going to break them down into the chronic disease management. There's the three main things would be atrial fibrillation, heart failure, and then coronary artery disease are the main cardiac chronic conditions for GPs to be looking after. So arrhythmia monitoring during the pandemic, there's also a wonderful paper that'll be coming out in the Journal of the American College of Cardiology. It isn't released yet, but it gives you an idea of how to do arrhythmia monitoring. But this is something that lends itself to the outpatient telehealth service, because you can do it very well. So in patients with COVID, yes, they get arrhythmias, they can get ventricular tachycardia, they can get polymorphic ventricular tachycardia from the hydroxychloroquine that Donald Trump has been saying we should be using, which we shouldn't be using. Patients will get atrial fibrillation if they've had it before, or if they're extremely unwell, they're likely to get atrial fibrillation for the first time. And then patients who may just have palpitations at home and they have no formal diagnosis of atrial fibrillation, or they have known AFib and they're just not sure how often they're getting it. This is very easily monitored at home. First of all, I'd always try and teach patients to take their pulse. It's amazing how few can actually do it properly, and just to try and teach them what's regular and what's irregular so they can have an idea themselves. But in terms of home monitoring, there are two real devices that are CE certified and FDA certified, and these are the only two that we kind of restrict ourselves to in clinical practice. The first is the AliveCor. Now, the original AliveCor, which just gives you one lead, is fine for atrial fibrillation. It's fine for SVTs and PVCs and PACs and all of these things. But the 6 lead is the only one that's licensed for QT duration. We'll get on to why that might be relevant going forward. So the 6 lead Cardia is very good. And then the Apple Watch is licensed for atrial fibrillation detection. Now, this is a double-edged sword. We have, as predicted, been inundated with people with relatively asymptomatic dysrhythmias picked up on their watches, and we're not sure of the clinical relevance of this, but certainly it is generating some health anxiety. But for arrhythmia detection in at-risk patients, I think these devices are very useful, as long as it's not like the blood pressure monitors where people, it's a self-fulfilling prophecy. They do their blood pressure, it's a bit high, they get anxious, it gets higher still. So in selected patients, these modalities are very good. I just wanted to talk about atrial fibrillation, and just to try and calm people about it, for want of a better term. Atrial fibrillation is very seldom an emergency. A lot of patients with atrial fibrillation don't even know they have it. And just because somebody has atrial fibrillation does not mean they immediately need to go to hospital, or even have to go to hospital in the relatively near future. So people with atrial fibrillation who are unduly breathless, have chest pain, have evident heart failure, or are hypotensive, yes, they need to come to the hospital. We need to see them straight away. In people where they just say, I've had a bit of a flutter for a week, or haven't been quite right, a little bit more fatigued, maybe a little bit of exercise intolerance, you can absolutely put them on a beta blocker if they're suitable, put them on an anticoagulant, and then refer them to outpatients. That's absolutely a reasonable way to do it. And we will see the ECG, we'll contact the patient, and as long as they're stable clinically and their heart rate is below 110 on average, and as long as their stroke risk has been assessed and treated, they can quite comfortably be managed in the community. Yes, they do technically need an echocardiogram to assess their mitral valve, because if you have moderate to severe mitral stenosis, you shouldn't be on a NOAC, you should be on warfarin. But in general, atrial fibrillation, it's very common. It's very seldom a big clinical issue. And actually a big study that came out this year in Holland showed that if there's integrated care between primary care and a hospital in the form of a nurse and a cardiologist, the morbidity and mortality of AFib drops dramatically by almost a half. So I think collaborative care there is very important, and GPs can do a fantastic job at diagnosing it with an ECG or a rhythm strip, doing the CHADS fast, putting them on their treatment with beta blockade, etc. And that's very easily done. And so this is just something, again, from the ESC about a new AFib in somebody with coronavirus, and if they're unstable, you shock them. And if they're stable, you slow them down and anticoagulate them. It's the same as before. There's nothing really magic about that. But absolutely more than capable of looking after atrial fibrillation almost from start to finish in primary care. Patients then with more advanced dysrhythmias, they'll generally will be on our radar already. They might have an implantable device, such as a loop recorder or an ICD or a pacemaker. All of these things can monitor rhythm strips. Don't worry about these. This is an ICD that's just detecting atrial fibrillation. So it starts off in the top left. There's the upper line is the atrial lead, the next line down is the ventricular lead, and it goes A sense, V sense, A sense, V sense. Then they go into atrial fibrillation. So you can pick up all these high atrial rate events on these devices, and then you can pick up ventricular tachycardia on that device as well, very clearly. So the people with implantable devices, they again don't need to come into hospital unless there's a high alert from that. They can transmit all the data. We can diagnose remotely what they have, and quite often we'll have new atrial fibrillation picked up on one of these devices. The QTC, I think, is a little bit less relevant now than it was a month or two ago, because we were very worried about the correct QT interval because of hydroxychloroquine and azithromycin potentially being used in combination for treating coronavirus. But obviously that's essentially fallen out of favour because Coalition 1 and 2 have just shown that they don't really work. Remdesivir, which is the one that the FDA were rushing through as an antiviral, we don't know if it causes QT prolongation, but there was a warning associated with it. But basically, this can go out to any of the drugs that you're worried about the QT. This just to put it a ballpark figure, you know, you're talking about 420, 440, etc. But if you're starting somebody with coronavirus on drugs, we're talking about people who be low risk as if their QT interval is less than 500 milliseconds, okay? And then you give them the drug, and then you see what happens to their QT. Are they QTC reactors? Because your QT varies beat to beat, depending on your state of arousal, your heart rate, all of these things. And so if you've got a QTC that prolongs by 60 milliseconds or goes above 500, or if their QRS is already long, if it goes above 550, then you might need to change that. So you can kind of use this as a guide in these patients. But in general, we want the QTC, the lower the better, and in your patients, you do want the QTC below 450 if you can manage it. But if somebody's sick with COVID and needs these treatments, even though most of them don't work now, then you would want to be looking at 500 as your cutoff. And then this is what the ESC basically says. If they're below 500, you can fire ahead, otherwise you need to do the ECG. So Torsad is obviously what you're worried about. So you get QT prolongation. This is what people with long QT syndrome, when they're trying to avoid all these QT prolonging drugs, can get. And a lot of the drugs in COVID, electrolyte disturbances, bradycardia, these can all predispose you to Torsad. And it's more common in females and people with LVH. And so the treatment for Torsad, just so you know, hopefully it won't happen in primary care. You stop the offending drug, obviously. You want to normalise their electrolytes, and you want to speed their heart up, because a lot of the time Torsad will actually be due to a baseline bradycardia. So you'll correct the Torsad, maybe with a shock, or maybe just letting them correct themselves, but then they'll be bradycardia and they'll go back into Torsad. And sometimes they need isoprenaline or pacing. But again, that's something you don't need to know. But that's why you're worried. This is why you're worried about the QT interval and why people obsess about it. It's this Torsad point that you need to look out for, this polymorphic ventricular tachycardia with long QT. We won't bother with that. You can look at that in your own time. That's just about the different types of ET and the treatments that you can use. But basically, if somebody's unstable, you shock them, and otherwise then you'll try amiodarone if the QT isn't prolonged. So heart failure is my own subspecialty, and it also lends itself very well to monitoring and treatment in the pandemic. You can do an awful lot of this remotely. Heart failure patients should be very well educated. They should be into it, into their own health, looking at their weights, knowing their symptomatology. So heart failure, we've already been doing virtual clinics with heart failure clinics for years. So I think this is something, they will still need to come to hospital. They're very brittle patients, vulnerable patients, and they will need to come to hospital, and they'll need their renal indices checked. But in general, this is something that you can do a very good job in primary care of looking after. Because of everything we mentioned, people with heart failure are going to be vulnerable for COVID as well, in terms of more likely to die because they're worse off ab initio. But also all these things that go wrong in COVID can trigger a heart failure event. As I said, heart failure is perfectly modelled for telemedicine, and I'll bring you through what a virtual clinic looks like for us in heart failure. So, first of all, you would just contact the patient. Hopefully you'll be able to see the patient or not, but whether you just ask them how they're doing, what's their NYHA status, how breathless are they, can they carry their groceries, can they go up the stairs, can they go for a walk, can they have sex? All these important things you have to ask them and find what their limitations are, and you have to keep track of that and see if they're getting better or worse. You'll have to say, how are the tablets going? Are they getting a cough from their ACE inhibitor, gynecomastia from their spironolactone? All of these things, you need to ask these things too. Are they taking their tablets? What's their dietary compliance like? And then you might ask them, okay, let's try and get a few vitals. Let's do a remote examination. Show me your blood pressure diary. What kind of readings are you getting? Are you getting dizzy when you stand up? How often is your blood pressure this high all of the time? What's your average heart rate on this blood pressure monitor? We want it to be less than 70 in heart failure with reduced ejection fraction. What's your weight doing? We're looking for a jump in 3 kilograms as being a red flag for contact, but obviously it needs to be weighed at the same time each day with an empty bladder, virtually in the pajamas usually, or a bathrobe, just to try and give a consistent baseline. And so patients need to be up to date with all that. They need to be au fait with it. And that's when you decide what you're going to do. Okay, you're on this dose of tablet, we should up titrate it, or your blood pressure is a bit low, we should reduce that. All this can be done remotely. What can't be done remotely, though, is safe up titration of medications, because apart from the beta blockade, all the heart failure medications that we use, the spironolactone, the ACE inhibitors, the ARNIs, they all require renal monitoring. And how often? Well, if you make a dose change, you should check within 2 weeks. And then a good rule of thumb after that is if they're on a stable dose, what's their eGFR in mils per minute? Divide that by 10, that's the number of months you can allow lapse between rechecking. So if somebody's eGFR is 60, you can probably check their stable renal profile in 6 months' time. That's just a useful rule of thumb. But in the early stages after discharge, heart failure patients need lots of visits, and unfortunately they do need blood tests. And I'm not sure if point of care blood tests will be helpful or not, but certainly if somebody comes in under the cover of darkness to phlebotomy in the hospital and gets a blood test done, that's reasonable. But so you're pushing up your ACE inhibitors every 2 to 4 weeks. You're checking your renal profile each time you do that. The MRAs, the mineralocorticoid receptor antagonists, that's your spironolactone, your eplerenone, you're doing that more slowly. And we'll just keep an eye on the potassium, particularly with that. And so that's the big thing that I would worry about with heart failure in the community, is the renal function. So this is just another table from my colleagues in Switzerland, where they said what they do in terms of looking after the renal profile. And it's very common sense that if you've got somebody on an ACE or an ARB, and if their creatinine jumps by 50%, you might want to have the dose of what you're giving them and then recheck. And if their creatinine doubles, you might want to stop the dose and wait for it to settle and reintroduce at a lower dose. So this is just very simple guidelines as to what you can do and what you should be doing with tablets when you're managing these heart failure patients and doing the very tricky titrations. The other thing I suppose really that's important is diuretic use in these heart failure patients. Diuretic resistance will happen. Patients will be non-compliant with their medications. They'll be non-compliant with their diet. And so basically the diuretic requirement is going to vary depending on the temperature, their fluid intake, etc. And that's just an art, and each patient will be different. But in general, if their renal function is stable and their volume loaded, you're just going to be either increasing the dose or frequency of the diuretics. But if you're increasing the frequency, you want to make sure that the diuretic is actually working first. So if they're on 40 of frusemide and their weight is going up and they say, I take the tablet and I can go out for a walk, I don't need to go to the toilet at all, that 40 milligrams isn't enough for them. You need to increase that dose. And you need to keep an eye on their sodium and their creatinine when you're doing that. But if they are getting a good diuresis from, say for example, they're on their frusemide 40 in the morning and they're peeing out loads and loads in the morning, but then they're retaining salt for the rest of the day, that's when you can do your BD diuretic to get rid of an extra load of salt in the afternoon as well. So these are things that they can be managed. They take a lot of practice and repetition, and education of the patient is very important, because what can go wrong here is the acute kidney injuries, the hyponatremias, the volume depletions. But as long as patients are clued in and they understand what's happening, it can be done quite safely. So again, the challenge is, this is reiterating what we were saying, accurate volume assessment I would say is very difficult. But you can make a good fist of it. What's their known dry weight? What's their weight now? Do they think they've got puffy ankles? Are they orthopnic? Do they have PND? Are they more breathless? You can have a good fist of whether they're volume up and then volume down. They'll be lightheaded standing up. They might be oligoanuric. They might be thirsty all the time. They might be getting slightly confused, all of these things. The electrolytes and renal parameters, all we've already mentioned. You should absolutely be keeping a close eye on that. And the drug titration we've gone through, and diuretic we've gone through all of this. Great. Cardiac rehabilitation is another thing that we are trying to continue. During coronavirus, our cardiac rehabilitation nurses are contacting patients. It's very important for people who have gone through an acute event during the pandemic that they get appropriate rehabilitation to ensure that they improve and that they are compliant with medications and lifestyle changes. And thankfully, you can do very good cardiac rehabilitation remotely, and it does improve drug compliance and functional parameters when it has been studied. And then finally, the chronic coronary syndromes, which is just basically coronary artery disease excepting STEMIs, non-STEMIs, unstable angina. So chronic stable angina basically is what we're talking about here. It's just I want to point out that these patients are very stable. People with chronic coronary syndrome and chronic stable angina, their coronary anatomy is probably bad. They probably have significant narrowings. But those narrowings are stable. They're not hot plaques. They're not plaques that have been recently disrupted. And so they tend to be quite stable. and they can be medically managed quite optimally. So what the ESC says is you should keep going with all the medications. Statins are helpful in COVID. At the ESC they showed that as well. So people with coronavirus should be on statins if they've got an indication for it. You should be following them up with telehealth. Unless they've got acute pain, then you need to see them. You can postpone their revascularization in most of these patients, that you don't need to be doing stress tests. And they feel that you can not quite sit on them, you still have to be careful, but you don't need to rush them to hospital. And people who are unstable are people with new symptoms or worsening symptoms within the last 2 months. That's the kind of the hot plaque territory, where there's a plaque in the artery that's ruptured and it's at risk of rupturing again and occluding the artery and giving them an MI. So new symptoms within the last 2 months, that's your kind of your yellow flag there. So the ischemia trial, which I'm sure you'll have heard about, that's what makes the ESC so confident that you can sit in these patients. These were basically patients where previously we would have almost certainly stented them straight away. They come with moderate to severe ischemia based on non-invasive tests. So that's a really bad stress test, loads of ST depression, or a stress echo or an MRI. And then all they did was they made sure they didn't have really bad ventricles that weren't squeezing very well, and made sure they didn't have left main coronary artery disease. And then they randomized them to either tablets or stents, and they found no difference in the patients. There are a few little caveats with that, but in general, if somebody is stable, you can just treat them medically. This is just to show that there was no real difference between the groups. So you've got lots of anti-anginals. I'll breeze through this. The only ones that you really don't want to combine, if you can avoid it, are beta blockers, ivabradine, and then the non-dihydropyridine calcium channel blockers. They can cause bradycardia, but they are all good in their own rights. They're all reasonably good anti-anginal medications. So short-acting nitrates, the cornerstone, sprays under the tongue. You all know about that. They can take it prophylactically or when they're on the walk with getting the symptoms. They just need to be careful about phosphodiesterase inhibitors. They just need to be very careful. Long-acting nitrates, nitrate patches, same restriction. You need to be very careful with the phosphodiesterase 5 inhibitors. You get what's called tachyphylaxis, where these long-acting nitrates become less effective the longer you're on them. Another first-line treatment, which is very good, is a beta blocker. It's good for angina and for reducing myocardial demand. You know all about the side effects of beta blockers. The one thing I'll say about that is that a lot of that is a nocebo effect. They've gone through this in great detail. And yes, it can cause bradycardia, but the fatigue, the low mood, all these things appear to be nocebo effects rather than true class effects. Calcium channel blockers, we're really talking about amlodipine, lercanidipine and things like that here. They cause vasodilatation, reduces preload and afterload, reduces cardiac workload, and you feel better. Ranolazine then would be a second-line agent, works in a different way. It's an agent that stops this late inward sodium current, which then allows less calcium to build up inside the cell because it gets antiported with the sodium. So you're reducing these calcium shifts in the cytosol, and that allows the myocardium to relax better, reduces oxygen consumption. It also has a metabolic effects with fatty acid versus glucose oxidation, but it's quite effective in terms of angina relief. So you've got a real armamentarium of medications that you can go through. Ivabradine, that's for people who can't tolerate the beta blockers because of side effects. It's pretty hemodynamically neutral and reasonably effective. Nicorandil we don't use too often. You can get this gastric ulceration and these oral ulceration that only go away when you stop taking the tablet. But again, if you're out of options, this can certainly help. Trimetazidine, there was a big trial just came out in an old drug where it switches you from fatty acid oxidation to glucose oxidation, and they were trying it after PCI, and it's a reasonable option as well. So just running out of time, so just going to wrap up, telemedicine is probably the future. We've got lots of things in heart failure. This CardioMEMS is a pulmonary artery pressure monitor, so you can see what the filling pressures of the heart are like before the patient gets heart failure. We do need guidance from the government as to what we can and can't do in terms of privacy and access to healthcare. Also need to figure out who's going to pay for all this healthcare. And the electronic stethoscope I'm very excited about. So in summary, cardiac involvement in COVID is bad for you. Amazingly, a troponin rise is bad. Who would have thought that? You may develop LV systolic dysfunction. maybe there is myocarditis, maybe there will be lots of heart failure in the future. We probably would have seen a lot of it already if that were the case. Patients can get AFib and other dysrhythmias. Virtual clinics are very useful for stable patients where you're just doing follow-up, and they should be utilised more. A lot of cardiac procedures can be safely postponed, so you don't need to worry about a lot of those things. And then chronic disease management is all about patient education and appropriate medications at appropriate doses, and that can certainly be done in the community quite effectively. This has been recorded a few days in advance, so I'm looking forward to being blindsided by something in the future, and maybe everything will have changed in the next 3 days because COVID is moving so quickly that there's new data every week. So thanks.
James, thank you very much for that talk. It was very useful, and I think it highlighted a number of the challenges that we're facing, particularly during the COVID period. We've had a number of questions and I suppose requests for comments as well in that I might just go through with you. The first question relates to exercise in the post-COVID period, because a lot of GPs have had patients who've gone through COVID, have come out of it, are reasonably healthy and active and want to go back exercising, jogging or whatever. What would your general advice be in that situation?
Thanks, John. First of all, I just hope nobody got motion sickness watching me do my talk. I had it on in the background and I was getting busy just looking at all the motions I was going through. The exercise post-COVID, I suppose the thinking would be obviously if there was an ongoing inflammation in the heart or a myocarditis, or if there was an incipient heart failure, that you could do yourself harm by exercising during active inflammation. When somebody is recovered from COVID in terms of their initial symptoms have gone and they've gone through the recovery phase, and they may enter this post-COVID period where they're fatigued, breathless, exercise intolerant, etc., there's going to be a spectrum of responses. Obviously, I would obviously take it slow at the start, ease yourself back into it. If you're symptom-free during a little bit of exercise, start off walking, brisk walking, short runs. If you're symptom-free, you're probably fine. If your COVID course was typified by things that could have suggested myocardial involvement, so say, for example, you had a lot of chest pain associated with it, or if the patient has new ECG changes when you've seen them, obviously you'd have to be more careful. But once they're out of the acute phase, it would just be slow and steady getting back into it and see what you can do. And then if you can't do a lot, then we'd start thinking about have they developed heart failure, etc., beyond COVID, but I wouldn't think so. So I think in the throes of the infection, you're not going to be well enough to do much, but that would be probably the danger period in terms of dysrhythmias and worsening myocardial function. But I think when you're in the recovery phase, it's just like recovering after any illness or any injury, even just getting slowly back into it. And if you're tolerating it, you're doing fine, then I wouldn't be concerned. And certainly things like if you're getting exercise-induced palpitations, lots of ectopic beats that are becoming more frequent, or you're getting symptoms of heart failure like orthopnea, then yes, maybe there's a slight more cause for concern, and you should see the patients and do their ECG and refer them on if needs be. But in general, I wouldn't be overly fearful about getting back to exercise if you were previously fit and you had symptomatic coronavirus and you're a few weeks after it. Just get back into it nice and steadily, and just be aware of what's happening in your own body. Listen to your body, what it's telling you, if you're able for it or not, and try not to push the boundaries too soon.
Very good, thank you. And the next question relates to the inflammatory response, I suppose, and the cytokine storm, which you mentioned, which we've all heard quite a lot about. And someone was wondering about, is there a role in terms of steroids or non-steroidals even, in terms of dampening down that inflammatory response, particularly from a cardiological point of view?
So yeah, I suppose there's two types of inflammatory response that you're worried about. There's the cytokine storm, is the very extreme one, where you get loads of IL-1, loads of IL-6, the patient is extremely unwell, they can get vasodilatation and shock, basically, and these are the young people that you hear of, the young people dying of COVID. A lot of the time it is the cytokine storm that makes things so difficult. They start getting endothelial activation and clots and leaky capillaries and everything. So high-dose steroids have been shown to be very helpful in critically ill patients. Recent meta-analyses show that high-dose steroids, first discovered, I suppose, in the UK, the NHS started doing it, and then they started producing the evidence. But it probably probably does work. On a smaller scale, if you have any kind of systemic low-grade inflammation, do steroids help with that? Do anti-inflammatories dampen that down? In terms of cardiac outcomes, I wouldn't say there's any evidence at all that it would help, and potentially harmful. If you think of people who have rheumatoid arthritis and they have this chronic low-grade systemic inflammation, their endothelial lining is dysfunctional, and anti-inflammatories actually worsen endothelial dysfunction. They stop prostacyclin production and a lot of the local prostaglandin production. That's very important to keep a healthy endothelium. So theoretically, if you're taking anti-inflammatories, this is why we don't give people with coronary artery disease anti-inflammatories. It worsens their endothelial function. People with COVID are pro-inflammatory, they're pro-thrombotic, they're prone to plaque destabilizations and PE. So anti-inflammatories would potentially worsen that scenario rather than make it better. And then in terms of the steroids, possibly cleaner. But in people who aren't critically unwell, no, I wouldn't go on routine. I wouldn't go on a small dose of pred or anything like that, because again, that causes a lot of metabolic issues, hypertensive responses, endothelial dysfunction, etc. So I would restrict the steroid use really to the critically unwell patient, unless they've got another indication for steroids at that time. But no, I wouldn't see a routine role for it. Obviously, tocilizumab and all of these anti-IL-6s, etc., are also helpful in acute cytokine storm situations or cytokine induced syndromes, but not in your general punter at home who's just feeling not so great after COVID with a few muscular aches and pains and post-COVID fatigue. I don't think there's any evidence, but I could be wrong. I don't think there's any evidence for steroids or anti-inflammatory.
Yeah, very good. And the next question is a two-part question, James, I suppose, is one, when to refer, I suppose, for cardiac MRI, and then two, when to refer generally. If you have a post-COVID patient, what sort of things should we be looking out for that we feel needs cardiology referral?
Yeah, so I suppose the longer term or medium term sequelae of coronavirus, we only really have 9 months experience at this stage of COVID worldwide, and the main things cardiovascular that we want, obviously during the acute phase, as I said, they can get really unwell. But in the recovery phase, the main thing is, have they been left with heart failure, and have they been left with myocardial scar? So the symptoms they'd want to look out for that would be your typical heart failure symptoms of exercise intolerance, pronounced breathlessness and exertion. I agree in COVID that can be multifactorial. As Oisin would have said, you can get a lot of pulmonary damage longer term or medium term. But in terms of the heart, I'd be looking specifically for heart failure symptomatology beyond just feeling unfit. I'd be looking for increasing ectopy, sustained palpitations, ECG changes. All of these things would be where I'd be saying, oh, look, better get a cardiologist to see you. The MRI question is very difficult, because what I would say is that, yeah, we have 6 to 9 months. If COVID led to fulminant myocarditis and a huge incidence of heart failure, we probably would have seen a big wave of heart failure coming through the doors worldwide, and we're just not seeing that. So I think there's reason to be optimistic that the longer term sequelae won't be there in terms of heart failure. All these studies that were in a small number of patients that were asymptomatic and showed that a lot of them actually had scarring or had T1 and T2 abnormalities in MRI that led to just muscle thickening and edema respectively, and then this late gadolinium enhancement that shows scarring or extracellular fluid expansion. These abnormalities, yes, they're present, but have we done the studies in any other virus, any other condition? People get flu every year. We don't routinely do cardiac MRI. How many of them will have some degree of myocardial injury or myocardial damage? You just don't know. So cardiac MRI is a very scarce resource, critically scarce in Ireland. And I wouldn't really see routine cardiac MRIs for COVID patients to be a good use of resources. If somebody came in with obvious heart failure, we would definitely do an ECG and an echo. And if the echo showed significant LV dysfunction, or they had troponin rises, then the MRI would be useful. But in terms of the thinking being, I have this COVID patient, they're after coming through them, they're young, they're exercising, they're a bit breathless, I'm going to send them for an MRI to make sure they don't have scarring. I don't think that's feasible, and I don't think it's necessary, and I don't think it's potentially useful either. I think the echo will do a lot of the prognosticating for us, allow us to initiate treatment if need be. But so I would have a high bar to refer for cardiac MRI. A, because it's scarce, and B, because I'm not sure if it'll be worthwhile. And then if you have any concerns about any of the patients, just send them to us, but specifically if there are new ECG changes, if they've got heart failure symptomatology or dysrhythmia, that would be my recommendation. And of course, ongoing chest pains, we definitely would want to see an emergency.
Yeah. Thanks, James. And I suppose finally then, and I've asked the others, Oisin and Karina, this as well, just looking into your crystal ball, there's a bit of concern, I suppose, about the winter ahead, and is it going to be, are we going to be swamped, I suppose, with a combination of flu, COVID, COPD, cardiac failure? How do you see things going through the winter, and what's your feeling on things?
I'm slightly more optimistic. I suppose at the start of when we had the heavy lockdown in March and through April, I was very concerned. There was, as I mentioned, the drop in MI presentations, and how many people were just out there having MIs, and just like when I was in Kerry General as an SDR, there were people coming down from the peninsula who had STEMIs 4 days ago and didn't think much of us, and just came in because their GP told them I should get a checkup, and they'd had a completed infarct. We're still not seeing the after effects of that, so I think it's a testament to the systems that were put in place, the virtual clinics, the GP clinics, and the people keeping in contact and keeping the chronic disease management in place, because a lot of the patients, we did have a rush on people being referred at the end of the lockdown when we opened back up. We did have a rush, but very few people in extremis, so I think people did a very good job during lockdown. And I suppose, as the guys have mentioned, Oisin mentioned the reduction in flu in the Southern Hemisphere, a 95% reduction. That obviously all goes very well. I'm not sure if it will translate to us, but do I see a difficult Christmas coming up? Absolutely, because it's been the same every other year. I don't see why this year will be different, but hopefully with COVID increasing hospitalizations, maybe the reduction in flu, uptake in flu vaccination, etc., might protect us. I hope that we do have plans in place to expand, like you saw the tents going up in front of the Mercy, that these could all be done again if we did get inundated. I think we're cautious. I think we're better prepared than we were in March. We haven't seen a huge tsunami of MIs and decompensated heart failures, which again is testament to all this, but it won't take a lot for these people to decompensate, and winter is the time. But I think we're prepared, and I think we're a bit more au fait with managing patients remotely, and I do think that staying out of crowded spaces and staying out of hospitals is to the benefit of patients and those vulnerable people who are protecting themselves, and masks and physical distancing. I think that will have a beneficial effect. So I am optimistic, but mainly because we are prepared, because we have more of a handle on treatments that work, and that I think everybody is now au fait with how we're doing medicine these days in terms of virtual clinic.
Great, James. That's a very optimistic note on which to finish. So I'd just like to thank you again for your talk and for your comments. Much appreciated.
Thank you, John.
Thank you. That brings us to the end of the morning. I'd like to first of all thank the three speakers, Oisin, Karina and James, for their views. I think it was very useful. I think we learnt a fair bit, and I think it's, as James said there, we're better prepared than we were in March, and I think that's a very cautiously optimistic note to finish. I'd also like to thank Menarena for all their help, support in organising the education morning this morning, particularly Frances Sweetman for all her work in doing this. It's challenging organising meetings in the current environment, but I think it's probably more important now than ever that we do embrace this, because the knowledge is changing and the knowledge base is changing all the time. I'd like to thank the IT people who are in the background, who I won't embarrass by naming, but thank you very much. And I hope you have learned something from this morning, and I hope you enjoy the rest of the weekend and stay safe and mind yourselves over the next few months. Gurmid Mahagat.